and deformity. Today we have about 14 speakers from about 11 countries, and they will speak about the same topics: the spine endoscopy, the deformity, and the fractures. First of all, I would like to thank Endovision company for sponsoring, from South Korea, for sponsoring this meeting. And special thanks to Dr. Vlad Tebeltevsky from Endovision, the chief consultant of Endovision company from South Korea, for assisting in organization of this course. I would like to thank all our eminent international and national guest speakers for joining us from different countries. It's a great chance for exchanging the experience between all the professors and between different countries. Many thanks for joining us. Now we will start with the opening ceremony. Professor Hani Mouafi, the treasurer of the Egyptian Orthopedic Association, will start with a brief talk speaking about the Egyptian Orthopedic Association and welcoming all the distinguished guest speakers. Professor Hani.
Thank you, Professor Ashad.
Professor Young.
Okay. It's my great pleasure to be here. I think it is among this elite distinguished professors all over the world from the spinal surgery, which it's my honor for me. And also I would like to thank Banha Faculty of Medicine and Professor Lashab for organizing this specialty days of the spine, and it's cooperated with the Egyptian Orthopedic Association, which is cooperated with Banha and Professor Lashab for organizing this meeting. Actually, I would like to thank all professors for this meeting yesterday. It was a great success for this day, and I hope that the next day or today to coming with a good day and also a fruitful for all for attendance. And also, I would good luck for all speakers, guest speakers. Thank you very much.
Thank you so much, Professor Hani. Now we will move to the second speaker, Professor Absalam Eid, the Secretary of the Egyptian Orthopedic Association and the Dean of Zagazig University in Egypt and the former head of Orthopedic Department in Zagazig University. Professor Absalam.
Bismillah ar-Rahman ar-Rahim. Dear Professor Muhammad Al-Ashhab, my dear colleagues, the members of the board of the Egyptian Orthopedic Association, Professor Hani Mouafi and all the others, our dear foreign guest speakers and all attendees. This is a great honor to participate in this world-known course. Professor Al-Ashhab has made great efforts to organize this and other courses and put Banha University Faculty of Medicine Orthopedic Department on
Salam, you are mute.
Salam.
This is a specialty meeting, and it includes experts in spinal surgery from different countries. And this is one of the interests of Egyptian Orthopedic Association to provide in-depth and cutting-edge knowledge in different orthopedic specialties, together with maintaining and educating the young orthopedic. This effort is a huge effort, Faculty of Medicine University, and this is in itself a major effort. I hope he will still have the energy and effort and time to organize these fruitful meetings for orthopedic surgery, in addition to his new work, which I expect, inshallah, will be a great success as we are accustomed from him. I hope you all a very fruitful meeting. I hope you all a very successful scientific day. And until we meet again, inshallah, either in person or online for the other activities of Egyptian Orthopedic Association, the nearest of which, inshallah, will be the Deformity Correction Conference, which will be next August. I hope to see you there. Thank you very much and have a great day.
Thank you so much, Professor Absalam. Now we will start our specialty day, our second day of the spine specialty day. First of all, I would like to welcome Professor Yang Hai from China. Welcome, my dear Professor, Professor Yang, and Professor Zhang from South Korea. You are very welcome, sir. Thank you so much for joining us. The first speaker will be Professor Mohsen Saeed from Ukraine. Professor Mohsen, you are ready, sir? Professor Mohsen?
Moment.
Welcome, Professor Mohsen. How are you,
Yes,
sir?
welcome to you, Doctor. Thank you.
Thank you so much, sir. You are ready, sir?
Yes. I will start it, my declared, Doctor.
Yes, sir. Would you please share your screen, sir?
Yes, I ready. I can to begin?
Yes, yes.
Thank you. Thank you. Thank you. I will start it. Thank you, Doctor. Welcome to you from Ukraine.
Would you please full screen, sir?
Ukraine, Odessa State Medical University. I am height of neurospinal surgery in Odessa State Medical University. I will teach my lecture and show you a very interesting presentation about future of treatment of hernia discus with using transfemoral endoscopy and biportal and ultrasound nucleoplasty. What's the difference between the method? Sorry. Yes. Yes. Speciality, according to who back pain in the most common reason patient seek medical help. Spinal osteochondrosis is the most common pathology leading to long-term pain syndrome, which lead to disability for more than 40% of people working in literature of 2006. In more than 15% of cases, the degenerative processes affect the lumbar spine, and 35 the cervical, and 13 the thoracic spine. The most severe from complication of lumbar osteochondrosis, hernia of intervertebral disc, which further leads of the development of stenosis. Stenosis of the lumbar spine usually has several points of compression of the nerve roots in combination with hypertrophy of the yellow barometrical ligaments and hernias of the nucleus pulposus, leading to stenosis of the lateral back and compression of the foraminal to nerve root to syndus morphitis. And fetus joints, hypertrophy, and reducing that interposterior size and or height of the article processes. The list of standard of surgical treatment of hernia discus in the lumbar spine is open microdiscectomy in our literature. And however, such in operation is not the best therapeutical solution science it has. Whole range of contradictions, long because long term of rehabilitation, more than few weeks, a high percutaneous of unit severity treatment sold according to the magnitude rating cycle up to 60% level show our control. Coronary various biportal and monoportal endoscopy method are wide used. To increase the efficiency of surgical treatment of intervertebral herniation discus various localization by the method of monoportal transfemoral endoscopy, discectomy, and ultrasound nucleoplasty to develop no algorithm for choosing the optimal treatment method. Material and methods. A retrospective analysis of treatment result from 2010 to 2020 was arrived about 188 patients with degenerative osteochondrosis of the spine and hernias of the lumbar spine of various locations. 74 patients, about 55 and 4 women and 44 and 6 men, underwent monoportal transfemoral endoscopy under local anesthesia. 114 patients underwent ultrasound nucleoplasty. All patients before and after the operation underwent MRI diagnostic, radiography, pelvis with L4 capture, ultrasound of the paravertebral musculus, and electromyography of the musculus of the low examination. Doppler of vascular of the low examination and another method. The patients were distributed according to the level of spine lesson, as you see in our graphic. Nucleoplasty was performed percutaneous puncture without injections. Access of the disc through the radicular canal. Duration of surgery up to 20 minutes in middle. And ultrasonic apparatus was used to low frequencies with the possibility of increasing the frequency if necessary. Puncture needle diameter about 15 G. Compression of radical canal unilateral and extraforaminal compression and compression of the central and radicular canal 1-2 degree or stable. Acute and chronic radicular syndrome. Contradictions to general anesthesia. I will show a short presentation about monoportal transfemoral by using local anesthesia. Indication for ultrasound nucleoplasty. Effectiveness or conservative therapy foraminal unilateral, bilateral radical syndrome, development of instability of the spinal segment, hernial sausage size up to 8 millimeter, radicular syndrome, and cerviphysical condition of the patients which does not allow for general anesthesia. The need of simultaneous surgical intervention at several levels for medicine disc herniation, most effective method. I will show a small presentation by nucleoplasty here about 10-12 minutes. Result. McNabb subjective rating scale. As you see, result agreed about 118 good result iteration, and well about 46, and satisfactory about 20%. Good performance completes about 156, and average indication retention of the function of the pelvis organs, and lower examination by more about 75%, about 27 patients. And delegation of the function about only 5 patients. Full vascular patency, good vascular wall tone about 140 patients, and normalization of vascular tone, how minishing things of the fluid to be disclosed about 27 patients. Weak vascular tone about 13 patients. For chronic stenosis, our conclusions. For chronic type of stenosis, people endoscopy UP is the best treatment. Endofusion, it's very famous and modern method. Now, South Korea, it's the better in chronic form of stenosis. P-portal endoscopy is also indicated for central stenosis of the spinal canal. For compression of the radicular canal, unilateral and extraforaminal compression, the method of choice is monoportal transforaminal endoscopy discectomy. It's very important to difference between two methods. Which is the best method, monoportal or biportal method of endoscopy? For median and interforaminal disc herniation, the most effective treatment is ultrasound nucleoplasty. What its result very important for any doctors who wide using malinvasive treatment. Ultrasound nucleoplasty is the most effective and general method of surgical treatment. Completed regression of pain syndrome is noted already on the operating table. 2 hours after surgery, the patients can move independently and can be discharging from the hospital. No age restrictions in performing ultrasound nucleoplasty, and particularly on restriction of the mastic state, and low reconcentrate of hernia, no blood loss, low thesis trauma. Thank you for attention, my friend, my colleague. Thank you for your conference and organization. Very good, very excellent.
Thank you so much, Professor Saeed, for this very interesting talk about a very interesting subject, sir. Thank you so much, sir.
Thank you. Thank you.
If we have any questions to Professor Saeed?
Yes, if you have any question, I'm ready to answer it.
Any questions from our dear speakers? And
yes.
our
Professor
yes, please.
Professor.
Yeah, Professor Young.
Yeah,
yes.
I have a question for,
yes, welcome.
For Professor Said. And in our country, most of the people who have a discrimination, we are using the radio frequency embolism elevation procedure to treat those kind of patients. So what do you think the difference between the ultrasound treatment between your treatment and the how about the radio frequency for the minimally invasive of the lumbar disc herniation? Thank you.
Используется какая-то методика для лечения прыжка. Какая разница между ультразвуковой и радио? Да, скажите, что малоинвазивно, меньше травм, меньше крови.
Ultrasound, as I show in my presentation, it's very malo-invasive treatment and very close in local anesthesia. And in we can to use it, this method in every age, no stopping. In 100 years, we can to using if have patients. And if have hernia discus about 8 millimeter, until 8 millimeter, it's the better. Very effective. What's we using? If we have big herniation after this size, we using another method which I show you in my presentation.
Thank you, Professor.
Thank you so much. Any other questions to our dear professor? Okay, thank you so much, sir. It's nice to be with us tonight. Thank you so much, sir. Thank you, sir. Our second speaker will be Professor Jung from South Korea. Professor Jung will speak about lumbar interbody fusion with biportal endoscopic technique. Professor Jung?
Yeah, can you hear me?
Yes, sir.
Yeah. Thank you. It is a real honor to give a presentation at this symposium. I am Sok Dong-jong, orthopedic surgeon in Jinju-Bon Hospital from South Korea. What I'd like to talk about today is biportal endoscopic lumbar interbody fusion in spondylolisthesis. As you can see at the below, the biportal endoscopic surgery has a lot of these advantages, especially in biportal interbody fusion, no transfusion, quick recovery, no infection. Let me start by looking at 5 different spinal surgery with biportal technique. This picture shows the lumbar disc herniation, while the video right show the overview of the surgery. The average operation time is around 27 minutes. Remove the disc. Next, this picture shows the foraminal disc herniation, and the video on the right shows the overview of surgery. Average operation time about 30 minutes. This is SAP. Right side, you can see the exiting route. Annulus, tear annulus, remove the disc. At the time, we secure the exiting route. This one show decompression surgery in stenosis, severe lumbar severe stenosis. Right middle one is decompressive state. Right video is overview of the surgery. Ipsilateral decompression, contralateral decompression. Remove the ligament problem. The surgery was well done. Cervical foraminotomy and discectomy with bipolar endoscopic technique. Average operation time is 40 minutes. This video is C67 left side. Remove the ligamentum flavum. This is root 7. Tear dissect annulus, remove the disc. Lumbar interbody diffusion, average operation time 1 hour 20 minutes. Spondylolisthesis, postoperative X-ray. This is video. Medial facetectomy, remove the bone fragment, disc space preparation, insert the cage. Let me show you this graph for a second here. It is about learning curve in bipolar endoscopic surgery. Horizontal axis represents the number of cases. Vertical axis is the operation time in minutes. Four colors you see here show different type of bipolar surgery. Yellow is lumbar interbody diffusion. Red is lumbar decompressive laminectomy. Gray is cervical foraminectomy and discectomy. Blue is lumbar discectomy. As you can see, the graph flattens as we approach the 25th operation in all four types of surgery. Meaning that you can probably reach the average operation time after you perform 25 operations. This picture shows the open surgery. Left one shows the 3-level conventional fusion with 3-point transfusion. Right one is oblique lumbar interbody decision. In other words, only. The picture in the middle shows the severe degenerative scoliosis with right one is a post-operative X-ray with 3-point transfusion. This one is bipolar endoscopic lumbar interbody fusion. Left pre-op, right is post-operative. It took 1 hour 15 minutes, and the hemoglobin level is 13.4 and 12.3. Picture on the left show the stenosis, and the right one is a post-operative X-ray. This video is a short clip of the bipolar endoscopic interbody fusion. Partial laminectomy with osteotomy facetectomy and laminectomy. Medial facetectomy. Ligamentum flavum, remove the ligamentum flavum, dissect the disc, remove the disc material, and the plate preparation and the cage insertion. Before the insert the cage, we have to have end plate preparation, and then we grab the local bone into the disc space. This video shows the local bone graft through the funnel. Many bipolar surgeons use zero degree scope, but I used the 30-degree scope from the beginning. 30 scope has a wider view, as you can see in this picture. Left side is 0-degree scope, right side is 30-degree scope. On the same patient and the same condition. This shows here is a video comparing 0-degree scope, 30. First is 0-degree scope. Second is 30-degree scope at the same patient and condition. Bipolar surgery was performed from 2015. Among them, lumbar interbody fusion, 212 segment, spondylodegenerative or lactic spondylolisthesis is 116. Skin incision approach is a very important factor to make it succeed, especially for beginner. For lumbar interbody fusion, 2 skin incisions are located above its pedicle and a little more lateral than discectomy approach. This transverse incision is discectomy and decompressive surgery. This incision is fusion surgery. Grip is very important. In a right lesion, standing on the right side of the patient, you must grip the walking portal or distal portal with the left hand. Because the slope the lamina lies toward the distal part. In case of stenosis and fusion surgery, sometimes you can change the location of portal for sufficient decompression of hard to reach places. In other words, you should be able to use both hands in the walking portal. When inserting the cage, you need to use the proximal portal because of step up from the spondylolisthesis. We also took a video for your better understanding. Here I grip the walking portal with the left hand. I use always the hydraulic pump because it is easy to control the water. In the cervical operation, I shouldn't be over 30 millimeter HG, and a lumbar operation, it shouldn't be over 40 millimeter HG. I haven't have had complications which can be caused by using the pump until now. After removing the lamina and you remove the medial facet with the osteotomy, and then you can insert the cage into the disc space along the slope of the medial facet. For interbody fusion, when inserting the cage, especially spondylolisthesis, be careful of upper level exciting root. This is L3 root, exciting root. Above is L4 traversing root, KG insertion state. Picture on the left shows stenosis L3 for spondylolisthesis and L for 5 stenosis and spondylolisthesis. The middle one is a post-operative X-ray. This video is a short clip of this surgery: medial fascectomy, disc preparation, and the cage insertion. When you carry out this surgery for spondylolisthesis, there are several things to be careful for. Sometimes ligament flavum and dura are sticked together, so when removing ligament flavum, dura can easily tear. In the body, with step up, ST root is close to the disc space. This also you need to be careful. Lastly, in degenerative spondylolisthesis, there is always facet hypertrophy. It might cause confusion because it looks different from the normal anatomy. This video is a short edit of the entire barbital lumbar interbody fusion. Partial laminectomy with calcium punch. Medial facetectomy with osteotomy. Remove the bone fragment. Ligament flavum remove the ligament flavum. This is L5 root, traversing root, disc space. Contralateral decompression for rotated the right source with 30-degree scope. This is contralateral side. Detaching the ligament flavum from the bone lamina. Remove the ligament flavum on contralateral side. Disc space preparation and local bone graft through the funnel and the KG insertion. You can see the KG insertion state. From now on, there are cases of interbody fusion in lumbar spondylolisthesis using biportal technique. 54-year male patient. On the X-ray picture, the body of L4, L5 are contacted directly. There is a light spondylolisthesis. Light X-ray is a post-operative X-ray. It shows the restoration of disc height and the reduction of listhesis. 74-year-old male patient. You can see the spondylolisthesis L45. Right one is post-operative X-ray. The surgery was well done. 45 female patient, left axial grade 2 spondylolisthesis, right spondylolisthesis L45. Right one is post-operative X-ray. 72-year-old female patient, the body of L4, L5 is sticked together. In this case, you can have a reduction for listhesis. So we just have a decompression for root, the video and in situ fixation. The video above shows the procedure of the operation. This is exiting root. This is step up. Traversing root, exiting root. Sorry. This is one level spondylolisthesis surgery. The picture below, at the below, is two level biportal endoscopic lumbar interbody fusion. 51-year-old patient. This video shows the change the portal position. The first part is walking portal on the distal. From this point on, proximal side is walking. Left, first right hand working, cage insertion, left hand working. '76-year-old patient, she has severe stenosis and spondylolisthesis and facet cyst. So right X-ray is a post-operative X-ray. This is 76 female patient is severe stenosis L4-5, L5S1 spondylolisthesis and migrated rupture disc. We can do the surgery as that, like that, and two-level biportal interbody fusion. Very good reduction. Female patient, it is in case ligament flavum and the dura are sticked and the dura tear occurred during the operation. This ligament flavum removing the ligament flavum, dura tear, maybe 1.5 centimeter. I stitch up the dura with 7.0 nylon directly. Cage insertion and random to tear side direct suture perform the direct suture. 67 female patient, you can see the exiting root. We already have a lumbar decompression surgery. Close to disc spaces, this is exiting root. You need to be careful when inserting the cage. Sometimes it is difficult to find the disc space to the step up on the body. This is exiting. Above is traversing. This is cage. In revision lumbar interbody fusion, previously 5 years ago, she had two-level decompression surgery, but she had two-level degenerative spondylolisthesis and severe stenosis. You can see the revision. You can perform the revision two-level biportal lumbar interbody fusion. Okay. Biportal interbody fusion have a lot of advantages. So I think outcome is very excellent, and there is no transfusion and early recovery. So this surgery would be a good surgical technique for lumbar interval diffusion in spondylolisthesis lumbar. Thank you for your attention. Yeah.
Thank you so much, Professor Jung, for this very interesting talk. If we have any questions to Professor Jung.
Yeah.
Yes, Professor Zhang, I have a question. I have
Professor
two.
Jung.
First, you are using the biportal. It's a unilateral biportal or a bilateral biportal. I'm assuming you are using the unilateral, they call the UBE, unilateral biportal endoscopic technique to do the compression and fusion. And my question is the first, and how you achieve the nice reduction by using this technique? That's the first question. Second question, what kind of a bone graft you are using for the interbody fusion?
Yeah.
And the third question is, what are the fusion rate and what was the revision rate? Is there any revision for your procedure? And congratulations for the excellent work for more than 200 cases of spondy for biportal endoscopic fusion. Thank you.
Okay. First, how reduction is, I 7 years ago, I conventional flip surgeon. I am. At that time, we how to reduct is disc annulus tear and disc preparation. To some extent, we can have a little reduction. And second is using the script. Second question.
Okay.
Second question.
What is the bone graft?
Bone graft, local bone and BMD, DBM, local bone with DBM. So DBM. So remove the disc. We save the bone fragment, and so I just at the beginning I used the bow. I try to use Harrison punch and osteotome and chisel for having a lot of bone. Yeah. So the fusion rate I think need a further study. I am preparing the article and paper, and but compared with the conventional flip and the Ollie, result is like that. So I know I have no suspicion for fusion, but I need further study and article. Making the article, I try to do.
Thank you. So for a two level procedure, how long you take for this procedure?
Average operation time one level is not over 90 minutes. 2 level, maybe 2 hours.
Okay.
3 level, 2 hours. Sorry.
Wow. Great. Thank you.
Yeah. Thank you.
Excellent work.
Thank you.
Thank you so much, Professor Jung, for this very interesting talk. Now we will move to the next speaker. Anyone has any other questions? Okay, we will move to the next speaker, which is a very special guest, my dear Professor Young Hai from Beijing University, the capital university of China, and the Vice President of the Chinese Orthopedic Association. You are very welcome, Professor Yang.
Thank you, Professor Lisbach. It's my great honor again to join the Beihai University forum. Today, I will give a presentation for the experience of polysegmental post-column osteotomy for correction of kyphosis secondary to ankylosing spondylolysis. I'm from Beijing China Hospital. It's one of top hospital in Beijing City. We have 1,500 beds, and in the orthopedic department, we operate more than 4,000 cases per year. So we know kyphosis secondary to ankylosing spondylolysis is a very severe health condition. It compromises the patient, really impact the quality of life. You see the patient, they mainly, most of the patients, they are male, and the patient, they are disability, and the life quality is very low. So the goal of the surgical treatment, if the ankylosing spondylosis has been stable, we are most of the time, we are using the to not only correct the deformity, but also to restore the function, especially the patient when they are walking, the sight, the gaze, and status. So for correction of AS kyphosis, we definitely will use the osteotomy. And we know the osteotomy for spine will have pedicle subtraction osteotomy, Smith-Peterson or Ponty osteotomy, VCR, and also we have another procedure called a vertebral column deconsolidation. And according to anatomy, how many anatomy construct you take off, Professor Schwab has developed into grade 6 different anatomy. The different anatomy, the procedure has a different name, but the correction achieved is gradually increasing from 5 degree for single facetectomy to more than 6 degree by multiple level VCR. So how to choose VR for deformity is depend on the severity of the deformity, depend on the pathology of the patient, and also depend on the technique preference of a surgeon. And the most used 3 forms of osteotomy is one is a post-column osteotomy, pedicle subtraction osteotomy, and a vertebral column osteotomy. They have a different indications depend on how the curve was, the shape, how the sagittal vertical alignment, and you're gonna choose different. So for the kyphosis correction, for kyphosis only, the most 2 main forms of osteotomy, one is Smith-Peterson osteotomy, is including lately called a posterior column osteotomy and a Ponty osteotomy. It indicates for the long rounded kyphosis, and we can achieve correction of 10 to 20 degrees for each level, and it's a gradually correction segmentally. But for PSO, it indicates best for the angular kyphosis, and each level you can achieve 30 to 40 degrees of correction. It's for the localized kyphosis. It has a relatively higher complication. For example, over correction and the sagittal translation at the osteotomy site. We know the posterior column osteotomy in different regions of the spine has achieved different corrections. For example, for the cervical thoracic junction, each level you can achieve about 4 degrees. For the upper thoracic, 7 degrees. For the thoracic lumbar region, 11 degrees. For the lumbar is 9.4 degrees. Look at the picture, you see there is a little difference between Smith-Peterson osteotomy and the Ponty osteotomy. It's depend on how many anatomic construct you are taking off or you are resection. And for posterior column osteotomy, you are going to take all the posterior elements, including spondylosis process, the lamina, the bilateral facet joint, and also the ligament foramen. The best indication or the best correction you can achieve is you cut all the construct between the inferior edge of the pedicle in the up vertebra to the lower vertebra, the superior pedicle. So then you can achieve the most significant correction. We are using this technique before to treat adult rigid scoliosis. You can release the spine, you can do a derotation, and you can do a very nice corrections. Look at the base patient is almost 40 degree, and only several level of PCO. You not only achieve the coronal, sagittal, nice correction, also the derotation of the vertebral body. And later on, we developed this technique into we call the MIPO procedure. It's a multiple asymmetric Ponty ostomy to correct severe rigid scoliosis. For example, this patient is 29 years old with 130 degree of scoliosis and 100 degree of kyphosis. We did the exposure. We did a 6 level of a MIPO, which is an asymmetric multiple level Ponty osteotomy. At apex level, 3 level above and below. You see the correction was very nice and without any complications. We use this technique to treat the adult severe rigid scoliosis. For example, this is a 36 female. This is the 41 years old female as well. A nice correction was achieved and also maintained the very nice coronal and sagittal balance. This tech we have published our experience in the Spine Journal, also the World Neurosurgery Journal in 2019. Here comes the question. Is this technique can be used for the ankylosing spondylokyphosis correction? We did a prospective observation study to evaluate the efficacy and the safety of this procedure. The patient was under general analysis and to the surgical bag. That the surgical table was bended according to the curve of the kyphosis. This is the incision, and after exposure, and pedicle screw was inserted, and we did a 6 level of posterior column osteotomy at the apex and below. And then correction, you see after correction, several level 1, 2, 3, 4 level of the osteotomy site was closed nicely. And this is the bone grafting after the correction with the transverse link. And for the correction of the curve, there's 2 maneuvers you need to do. One is to restore the flat level of the surgical bed. This is what decrease the chance of screw loosening. And second is the compression segmentally to correct the kyphosis. You see, this is the patient we introduced at the first, a male 34 years old. After correction, 96 degree of the kyphosis restored to normal level, and the follow-up of 18 months, there's no loosening of the correction. From 2010 to 2019, we have 45 patients with ankylosing spondylokyphosis, and 29 cases of them did only post-column osteotomy instead of the PCA. The kyphosis average was 73 degree, and the 3 patients, not only kyphosis, also with scoliosis. There's no hip joint condition. 2 of the patients had a total hip replacement already. And for the osteocyte site, the highest level is T67, the lowest is L34. Average patient is the 4 level of PCO. The surgical time average is a little bit more than 3 hours, and the blood loss was 600 millimeter. We follow up this for at least 1 year, and there's only 7 patients with complications without any neurologic complications. Let's see some patients. This is a male, 32 years old patient with 74 degree of kyphosis, and we did a 5 level of osteotomy. We have a very nice collection. You see the patient, the smiling face. You see the results, how it's going. And this is the male for the patients. This is a rather severe patient. It's a very severe scoliosis, more than 100 degree, and it's a higher. We call the almost the chin on chest deformity. This is the surgical bed. This is the after correction. You see how the bed was changed, and we did the 6th level of a ponsiotomy. You see the correction. The eyesight gaze is from a 6 degree. When he was walking before surgery, he can only see like 5-6 feet in front of him. But after surgery, he can see far away from patient. The quality of life has improved a lot. This is another female 43 patient with more than 100 degree of kyphosis. We did several level of PCO with 1 level of pedicle subtraction osteotomy, and also achieve very nice correction. What if the patient has fused anterior ligament? You see this patient in 97 degree of kyphosis. You see the anterior edge of ligament already fused. Is this can be using the PCO? Actually, we're using the Mimic software and the 3D matrix software to restore, to stimulate the correction. This is the virtual surgical planning before surgery. We did a several level of Ponti osteotomy. You see that we have a posterior column at the T12, 11, 12, T12, L1, L1, 2, and 2, 3, 4 level. Each level we measured can achieve more than 10 degrees of correction. And this is the before surgery. This is the stimulated after surgery, 50% of the correction. And this is the surgical intraoperatively insertion of the pedal screw and the 4 level of the posterior column osteotomy. And you see the anterior longitudinal ligament was calcified and fused during the procedure after the take off the facet joint from pedicle to pedicle. We use the osteotome to cut through the anterior edge of the vertebral column. You very gently type the osteotome, and after you touch that using the furrow to moderate the position of the osteotome, and then you just gently twist it. You will hear a beat. You see this level, the ligament is broken, but because you are having each level fixation, so there's no translation before the osteocyte to prevent any neurological. You see several levels. This is the ligament is broken and broken and broken. So after correction, you see the anterior space all opened up, and we have a very nice correction. So this is after cuts through the anterior longitudinal ligament. This is the after surgery. You see the opening, and then there's no translation of the surgical site. Before surgery, after surgery, you see the kyphosis for 97 degree restored to 46 degree. Patient has a very good eyesight, and he's very happy, and especially his wife. So if the ankylosing spondylokyphosis with scoliosis, like this patient, 28 years old male, he had a very severe kyphosis along with 47 degree of scoliosis. He had a bilateral hip replacement before 3 years ago. Now he wants to improve his life because he cannot lying flat on the bed. So because this condition, all the segment of the spine has fused, there's no compensation mechanism or ability for this kind of patient. So during the correction, mainly the kyphosis, you have to consider to maintain the balance of the coronal plane, which means correct the scoliosis and some of the correct of the kyphosis and some of the scoliosis without causing any coronal imbalance. So we also did a visual surgical planning. We did an asymmetric posterior column ostomy for those patients, but you have to consider the rules. We did the simulation of each level. We compare both sagittal and the coronal, how much correction you needed to make. And then we perform the procedure. So this is the stimulation. This is during the procedure, pedicle insertion. You see, we did the 1, 2, 3 level of PCO is asymmetric, but the degree of the correction is less than it should be, because if you correct them too much, you will causing the imbalance in coronal plane after surgery. So by correcting you from one side using the counter level maneuver to push down to correct the kyphosis as well the scoliosis. This is after correction. This is the intro of the X-ray. You see we stimulate before surgery and after how the correction was done. And this is the patient before and after surgery. You see the patient has a nice correction of the coronal plane. The balance, coronal balance was good. And also the sagittal restoration was also good. The patient is extremely happy for the surgery. So when we can use post-colon ostomy for the kyphosis secondary to ankylosing spondylo, we are going to use it in the long gradual rounded kyphosis or kyphoscoliosis. And the segment is not fused or fused not completely, because you needed to open up the space. If there's a fused too much, the anterior ligament calcification is very thick, and then you'd be careful. If you combine with other type of ostomy like a PSO or VCR, it can be used at the cervical, thoracic, thoracico-lumbar or lumbar region. So polysegmental post-column ostomy for ankylosing spondylo kyphosis, it can avoid single level overcorrection or translation, less surgery time and the blood loss, less neurologic complication. It's effective and a safe procedure. We can say many small things make miracle. Thank you so much, and welcome to visit our hospital. Thank you.
Thank you so much, Professor Yong Hai from China. Thank you so much for this interesting talk, sir. Any questions to Professor Yang?
Thank you. Thank you for your good lecture. I am Sokung Jung, Dr. Jung from South Korea. I have a question. One patient have had the old compression fracture 10 years ago. The body height is decreased by 40%. When walking, she have progressive stooping. He wanted to correct the deformity. I have a question. What kind of osteotomy do you do for that patient?
So it's an elder patient.
Not just the cause of kyphosis is only due to L1 old compression fracture.
Okay, old compression for the single level causing kyphosis is relatively angular kyphosis. I was using a PSO type, either through pedicle or either through the intervertebral space to do a wedge-shaped osteotomy, closing osteotomy. If the kyphosis is more than 80 or 90 degree, you may do open and a close, anterior open, posterior close, some intervertebral space supporting to have a more rigid construct. So one level PSO or 3-column grade 4 osteotomy and 2 or 3 segmental fixation above and below. If the patient has a very severe osteoporosis, you may need a cement augmentation at the pedicle site.
Yeah.
Thank you.
Thank you. Thank you.
Thank you so much, Professor Young. Now we will move to the next speaker. Professor from South Korea is the next speaker. You are very welcome, sir.
Hi, how are you?
How are you, sir?
So, hello, good afternoon, professors.
Good afternoon, sir.
Yeah, thank you for having me. It's my honor to giving me this participate this webinar. And first, I'd like to introduce Endovision company, and Endovision product manager Ju will talk about Endovision company. Okay, let's give him just 10 minutes, and after that, I'd like to talk about my topic, endoscopic extreme delicate. Okay, yeah, I try. Can you see?
Not yet, sir.
Yeah, can you see the screen?
No, not yet, sir.
Sorry. Can you?
No, not yet. It's not shared, sir. Yes, it's starting to share. Yes.
Oh, yeah. Sorry.
The voice is not clear, sir.
Can you see the screen?
Yeah,
No?
I can see the screen, but the voice is not clear.
Oh, yes. Sorry. Thank you. Okay, sorry.
Professor Ohm? Dr. Ohm? I think Dr. Ohm had a problem with connection. Dr. Ohm, you are with us? Okay. Till Dr. Ohm solves his problem with the connection, the next speaker is supposed to be Dr. Professor Henry David from Philippines. Dr. David, you are with us?
Hello, excuse me. Hello, yes. Let me just adjust my video.
Dr. Ohm, you are with us? Dr. David, how
yes,
are
sir.
you?
I'm here.
How are you, sir?
Hello. Good evening.
Good evening, sir. I think it's too late in Philippines now.
It's past 10 p.m., sir.
Yeah.
In the evening.
Evening, sir.
Are we waiting for Dr. or?
You can start, sir, and when Dr. join us again, he will continue his talk.
Okay. I'll start now. I'll share my screen.
Okay, thank you so much, sir.
Let me just cue my slide. Okay, I hope you can see my screen, the blue screen.
Yes, sir. It starts to work.
Okay. First of all, thank you very much, Dr. Hosni of the Egyptian Orthopedic Association, and thank you, Dr. Elsa Elashab, and the Benha University Faculty of Medicine for inviting me. And also thank you to Endovision. Dr. Yum was making a presentation earlier. I have similar slides. Endovision asked me if I could say a few words regarding their product. I'll go through these slides briefly so that I can get to my original presentation. I just wanted to make a comment that actually I got to know Endovision because of my training in endoscopic spine surgery in Korea. And among the industry standards they have, their Endovision is one of them. They are of course known for their equipment. They make very nice endoscopic products, arthroscopic products, anything in the line of minimally invasive surgery. But of great interest to me, of course, is the system that they have for biportal endoscopic spine surgery. So they have a complete set. They have the scopes, they have the RF ablator systems, all the handheld tools, the shaver and burr systems. And just briefly, I'm very fascinated. I haven't tried this scope yet. I'm hoping they send me a sample of this, but the design is very ergonomic, better than the one I'm using right now. Also, they have an assortment of RF probes, which I believe you can use for almost any kind of maneuver that you need when you're dealing with soft tissue, with bleeding control for the spine. And I'm also looking forward to that. Of course, their burrs are, the nice feature of the burrs is they have power burrs that are very compatible with all sorts of burr tips. I myself use the Striker burr tip, so it goes well with this. And of course, in endoscopic spine, we use this a lot, the power burst. The K-punch, I haven't actually tried the rotating K-punch. I'm still old-fashioned. I use the traditional Kerrison, which we use for open surgery. I have yet to try the rotating punch. I know that it has very good ergonomic features, but I'm going to try this one of these days, and hopefully it will make a better difference than the standard rigid set of punches that I have. In passing, I'm very much I'm fond of using the pituitary forceps, the micro forceps that we use in endoscopic spine. They're very handy, whether it's a straight tip or the curved tip. Very easily adaptable to cervical, thoracic, as well as lumbar surgery. And this is, I guess, of their equipment line, this is the one I'm most fascinated about. I myself use a working port, cannula, trocar for the working port. But the problem with a trocar for the working port is that you're limited in the diameter. So if you have a bigger instrument, you need a bigger trocar, which basically means a bigger wound. The nice thing with this adaptable retractor is that it's open on two sides. So you don't have to make such a big wound. You can easily slide this over a dilator system, a tubular dilator system. And you can put in a relatively large instrument. The soft tissue will adapt, will accommodate, will stretch, and you don't have to make such a big wound. But you still maintain the channel, so it's easy to go in and out, especially as you advance in the surgery and the soft tissue becomes edematous. Okay? It allows you to maintain that channel, and so that you don't have any difficulty finding or going back in to your working area. And of course, they have their own line of dilators, of osteotomes. I myself have actually stopped using a lot of the osteotomes. I only use it if really needed. But ever since getting introduced to the burr, I'll tell you later how that came to be. I actually like using the burr more than the osteotome now. Okay, let's see. I think this is the last slide. Okay, so I'd actually like to go into my presentation. I gave a variation of this presentation earlier this year, again at the invitation of Endovision. I did a bit of retweaking because Now I'm talking to basically members of the Egyptian Orthopedic Association. And I don't know if there are any neurosurgeons in the crowd, but I will more or less be addressing orthopedics in general. Okay, the title of the presentation is Pearls and Pitfalls of Transitioning to UBE, spine surgery. So I just want to present a few practical tricks of the trade that I picked up along the way. So a little history about of how I got here. I am an orthopedic surgeon. I graduated medicine in 1999 in the UP College of Medicine. My first love was neurosurgery, if you actually can imagine it. I got into a neurosurgery training program in the year 2000 in Philippine General Hospital. It's a government center in the Philippines, one of the biggest ones. And the difference, well, the thing with government hospitals in the Philippines is that they are geared more for the financially difficult, the indigent patients that we have. Usually the patients who are capable of paying normally go to private hospitals. Those who cannot are helped by the government healthcare system. And PGH is one of those big hospitals connected with the College of Medicine of the University of the Philippines. So I actually started off as a neurosurgical resident, but the stress of having to be in a neurosurgical program, I'm afraid, ground me down. So I decided to move to a private hospital. And initially, I still wanted to do neurosurgery, but in a private hospital system, you have to pass through general surgery. There are no straight programs. So you have to do at least 2 years of general surgery, and I was thinking of doing that. So in 2001, I shifted to the Medical City, or TMC, and became a resident in that hospital. Uh, I actually ended up spending 3 years there before I got recruited. It was not my intention to go into orthopedics, but I got recruited into orthopedics primarily by Dr. Tony Rivera. You see him here. He is the father of arthroscopic ortho, sports medicine in the Philippines. In the 70s, he brought knee arthroscopy, he brought arthroscopic ACL surgery, and later on shoulder surgery to the Philippines. So he was one of the heads of the programs of Makati Medical Center. And the other guy, our department head at that time, one of the senior founders of the ortho program of Makati Medical Center, is Dr. Ramon Bustillo. The orthopedic people in the crowd will probably recognize his name. The very same Bustillo whose name we have attached to the Bustillo Open Classification of Fractures. So these were my bosses during my orthopedic residency for the next 4 years. So I graduated, I got my diplomate in orthopedics in 2007. And then 2 years after a bit of private practice, I moved to the Visayas region of the Philippines to train under Dr. Richard Condor, who became my mentor, co-author at certain times. He was the medical director for Asian Orthopedic Spine Institute in Cebu province. And he taught me a lot. He was primarily focused on spine instrumentation, on spine fusions. And it's a big thing in the Philippines. So I actually got trained in the area of doing spine fusions, lumbar, thoracic, and cervical fusions when I got started. And I did this for nearly 10 years, practically 10 years. I was doing mostly spine fusions. This is a clip of my YouTube page. I actually have a few representative film clips of the surgeries, the fusion surgeries that I've been doing in the past. Anywhere from cervical fusion, anterior, posterior, thoracic fusions, and mostly lumbar fusions, TLIFs. Okay, my initial exposure to spine endoscopy came quite recently in 2019. One of the Korean experts, Dr. Daejun Choi, was invited to speak in Medical City to do a workshop on lumbar spine endoscopy, biportal lumbar spine endoscopy. And I managed to attend. I was invited and I met him. And I was blown away by the idea of spine endoscopy because up until that point I had not really seen it yet. So it was a very fascinating field. And I said, how old is this? How long has spinal endoscopy been going on? Because it's relatively not heard of in my country, in the Philippines. So from that point, luckily the fifth ASEAN MISST convention Congress was held here in the Philippines, in Manila, June 2019. And I got to meet even more people doing minimally invasive spine surgery. Most of the highlights were in uniportal spine surgery. It's the more established school, the more established technique in spine surgery. But I also got to meet other people who also do biportal spine surgery. And that was a very nice experience for me, meeting all these people from different countries, a lot of the doctors, hearing them speak. And among the groups that were there were people from Daejeon Guri Hospital, the hospital of Dr. Cholgum Park. Later in that year, I would go to Daejeon City to train under Dr. Park. My training is not complete yet. Actually had to go home in February because of the pandemic. I could not stay there for long. I would want to return. Dr. Park invited me to come back, but right now, as you may know, the Philippines is one of the hardest hit as far as the pandemic is concerned. Our economy is in a wreck. We have not really fully controlled the COVID virus, so we are, we are really struggling through the pandemic. Everyone in the medical field, so it's a bit difficult to leave the country as of this point. But that said, okay, I guess the other significant thing about my history is that I was a teacher. I have been teaching for quite some time. I became an assistant dean of a medical school here in Cebu, and I still like teaching, but I would like to focus on my clinical practice now. So I actually resigned just before I started doing endoscopy training. So I shifted, not fully, but I've been doing more and more of spine endoscopy beginning in 2009 when I started to discover it. And that's basically where I take off. Okay, I'd like to introduce this. I included this in the title, the term hack. I like to use it because I'm so fond of what we see now in evolving spine technology, spine surgery technology, because these are, I guess you could say, hack. The definition being to cut or chop off, like with an axe or a knife. That's the traditional use. A more modern use, I guess, is to hack, meaning to say to bypass computer security systems. As in hackers, people who hack other people's computer accounts. But I particularly favor the definition of hack being to adapt to a situation or to bypass, to go around a particular obstacle, to overcome an obstacle, or to find an alternative solution to a problem. So for me, hack means that. It is the very pertinent, very important definition that I ascribe to it. And if you were to think of spine surgery nowadays, we still do open surgery, of course, for instance, for deformity correction, for trauma surgery. But a lot of the surgeries we do for degenerative conditions, for neural compression, are now becoming more minimally invasive. We started off with big surgeries, midline approaches that stripped muscles, took off a lot of bone. This is how I used to do my discectomies for the lumbar spine. I would do a midline approach. I would remove the spinous process, do a total laminectomy, and then do my discectomy. And then I slowly transitioned to a more smaller opening. And when I trained with Dr. Condor, he actually introduced to me the idea of tubular discectomies, tubular procedures. This is actually my father. Dr. Condor and I did surgery on him in 2008 for foraminal stenosis. So that's how I got started in doing smaller and smaller wounds, smaller and smaller operations. Now, around the time that tubular retractor systems were, of course, very famous, on the other hand, endoscopic spine surgery was also evolving side by side, particularly the uniportal system. And this one I was not aware of during this time. The only minimally invasive technologies that I was exposed to were these, and small wounds with other types of retractors. So come our last maybe half decade where biportal endoscopy is booming, I've sort of come full circle because as an orthopedic trained surgeon, I used to participate, assist, and even do knee arthroscopy and shoulder arthroscopy. And never did I realize that you could use the same instruments like this scope, the knee scope, to actually do spine surgery. So that's the thing I'm fond most with this particular approach to doing spine surgery. Okay, one of my favorite quotes from a guy who is very well known to do hacks. Best way to beat a problem is to make it work for you. So in transitioning to a new technique, there are some problems that you'll probably encounter. This is especially true for the younger people, the ones who are just starting off doing their practice, I guess, who are trying to find their place in the whole setup. Okay, so very briefly, I'm not going to talk too much about the technique because we have a lot of other experts who can deal with this, but I'd just like to share with you my insights on why bother adopting spine endoscopy. I'm not saying we're going to abandon open surgery. We still have that, yes, but why bother shifting to a new technology to begin with? Okay, one of the points of view, I guess, is the point of view of the patient. This is a patient of mine whom I did 3-level T80, 90-10 hemilaminectomy endoscopic. And once she awoke from general anesthesia, she was feeling fine. She had a problem with walking. She had ataxic gait, and a few months later, she recovered from that, coming from the decompression. I'm very fond of this picture because you can see the patient is awake and feeling comfortable just a few hours right after surgery. So one of the best things about doing endoscopy, I guess. Okay, one of the nice things with it is that you basically you reduce the instability which you would otherwise cause if you were to do an open technique or a technique that required a lot of bone removal, facet joint removal, stripping of muscles and ligaments. So that's one of the things that minimally invasive surgery brings, of course. You preserve critical structures, and this is good because you keep the stability. You reduce the risk of accelerated disc degeneration of adjacent disc disease. This is a patient of mine. I did his TLIF in about 5-6 years ago. He came back to me recently complaining of problems at the level above my fusion. So this is fine. He has no symptoms at the fusion level involving the nerve roots here, but now he's complaining of symptoms involving the nerve roots upstairs. And well, we knew that would most likely happen, but imagine if I had known this technology, maybe I could have saved him from it. What else? In the Philippines, as I mentioned, there are government hospitals and there are private hospitals. And of course, one of the draws, one of the attractions of a government hospital is you don't have to pay for the hospital largely, and you don't have to pay for the doctors or the consult. But of course, you still pay for the implants. That's how we do it here in the Philippines. More so in a private hospital where the patient pays for everything to a large extent. The implants, of course, the fees of the doctors, to the hospitalization. And so any way that you can reduce the cost of having to treat patients means that this helps the patients a lot. Cost is a big thing in how we practice medicine in the Philippines. Other countries might have better healthcare systems, and that's a good thing. But in the Philippines, we have yet to actually level up our healthcare system. So that's a big consideration, reduction of cost. Of course, one of the mainstays of endoscopic or minimally invasive surgery is reduced pain, faster recovery time, lesser use of pain medication, so on and so forth. More peace of mind on the part of the patient because the patient is saying, well, I'll spend less, I will heal faster, and I end up avoiding the long-term problems associated with bigger surgeries or more permanent surgeries. So that's the one half of the coin. The other half is, of course, to the doctor, the medical staff, or the hospital staff. We greatly increase the visualization. I love this very much. The fact that you can zoom in on what you're doing surgery on. And it's been said that the magnification is about 30 times, and you can clearly see your structures here. This is a slip disc of C6, C7, and you have the two branches of the nerve roots. And you have bone. So I like the view really. It's very nice to be able to go this close to the area that I'm doing surgery on. I'd like to compare that. Like I said, I mostly do endoscopic surgery now. I've done a bit of this, and between this view, the tubular retractor system and a microscope, versus the endoscope view seems, I'm more comfortable with it. I'm more confident with it. Of course, I guess it's a matter of getting used to. A lot of surgeons who have done mostly tubular retractor work and OR microscope work, you are probably experts at this. But between the two of them, I would rather get used to this more than this view. Okay, again, in the Philippines, as I said, implants typically cost. You have to wait for the patient to gather the money to spend for them. So any delay in gathering funds, it means a delay in doing surgery. And sometimes even us doctors will have to try and find other implants, different brands for the patient to choose from, just so that they can afford getting the surgery done. So if we do away with the implants, from our point of view, it's a very big plus for us, because then the patient can easily say, okay, let's have the surgery already. I'm ready. I'm good to go with it. Okay. Wound complications, pain complications, all these other late complications like adjacent disc syndrome. If we can reduce that, that's a big issue again for us, for the doctors, which means we have less to worry about as far as the patient is concerned. So again, more peace of mind on the part of the doctor and on the part of the hospital. The patients are happier. We get better results, arguably. And I would dare say that it's less work. Having done both spine fusion surgery and endoscopy, I would definitely say that doing endoscopy is a lot easier, less tiresome than having to do spine fusions. So, okay, going on. Hacks. I'd like to at least share what I've learned over the past nearly 3 years of this whole transition period. Things that have sort of made it easier for me to transition my practice and even the hospital where I practice in doing endoscopic work. Okay, so a few pearls shifting to endoscopic work. One of the things that really help a lot is having good imaging systems, and especially CT scans, 3D reconstruction CT scans, as well as MRIs. In the hospital where I practice, sometimes they find it strange that I order for a post-op scan, and they sometimes the radiology department will have trouble generating this 3D image because they're not used to doing it until I started doing endoscopic spine work. And I tell them, you have to get used to this. It's very important for us to be able to evaluate the patient before and after surgery. X-rays are not the only thing that orthopedic doctors order. So please get used to the idea of having to do scans. And for me personally, as the surgeon, the more scans I look at, the more scans I study before and after the surgery, the more confident, the better I get at dealing with the anatomy. So the anatomy becomes clearer and clearer the more I actually deal with the scans, both MRI and CT scans. So for me, they're a very big plus. If I can include them a lot, if I can teach the rad techs more on the anatomy, on why we do these orders, it's a big help. It helps the hospital adapt to the workload. Okay, percutaneous procedures. I'm glad that I'm talking to orthopedic doctors because I do understand that neurosurgeons probably will not be doing anything beyond maybe spine and cranial surgery. So for us orthopedic doctors, I don't know if the spine practitioners in the group still do general ortho. If you do fracture surgery and if you use fluoroscopy, this is a very big plus for you, for us, because it helps you get used to handling the bony work, the surgical side, by looking at the fluoroscope. And of course, it's minimally invasive surgery, so it helps you practice in that sense. It gets you better acquainted. And on the other hand, as far as the OR is concerned, one of my biggest difficulties when I started with endoscopic work was that the operating room, the staff knew that there was a C-arm fluoroscope, and they knew I would be using it, but they didn't really know how to set it up, so I had to do everything myself and teach them along the way, get them used to where the C-arm would go and what kind of equipment we would use, and just the simple thing of reminding the nurses and the OR staff, you should be wearing your lead gowns, your protective shielding, because sometimes they forget because they're not used to the surgery. There was one hospital I worked in where some of the nurses were mad at me because I was shooting fluoroscope and they didn't have any protective shielding, and I told them, this is you know that the C-arm is here, you should be entering here with your protective gear on. They don't like wearing it because it's heavy, some nurses anyway, but you have to wear it if the procedure is fluoroscopic. So it helps to get people acquainted, especially the OR staff, when you do a lot of fluoroscopic work. So for those who still have the opportunity to do fluoroscopic work, I highly encourage you to do it. Okay, I mentioned here ultrasound of other regions. Why do I mention that? I actually do a lot of ultrasonography now. One of the things I got taught as a resident was how to do blocks. Before it was just hematoma blocks, blocks of fractures, interarticular blocks. But later I started doing nerve blocks. Before it was just landmark based, but now with the advent of better ultrasound, with the advent of portable ultrasound systems, you can actually start doing your own blocks and start learning how to use an ultrasound. The good thing with doing ultrasonography is that it lets you get used to the anatomy. The images are different when you start it at first, but the more you look at the images, the more you scan, you get to realize this is the same anatomy. I'm dealing with the same structures. It's just a matter of getting used to looking at the ultrasound image. Now, the nice thing with ultrasound is that you can look at the anatomy in real time and not have to worry about X-ray exposure. And it's quick. You can move your scanner easily, and you'll see where you need to go. It's very fast and it's very exact, and it's finding more and more use in ER, in OR, in pain management, but in orthopedics as well. I love doing my own blocks. If I have the anesthesiologist around, I usually might ask the anesthesiologist to do the block, but I myself would like to grab at every opportunity to be able to do a block or to do a scanning just to be able to appreciate the anatomy better. For those of you, by the way, this is a segue. For those of you who would like to see blocks at work in orthopedic surgeries, you can actually do a few major surgeries and a lot of minor ones using ultrasound guided blocks. If you would care to look at my playlist of videos, it's on YouTube. Okay, arthroscopic procedures. I don't know if in your setting you still have the chance to do them as an orthopedic doctor. I still do arthroscopic procedures of the knee whenever I can. And of course, the obvious advantage is that you get used to the scope, you get used to the biportal approach technique. The knee is very easy to scope because it's a big joint and there's already a working space. It's easy to develop your space. And it also trains the OR staff how to deal with the equipment, with the setup. Mostly the OR staff will know how to deal with the endoscopic tower because it's not only ortho that uses the scope. Of course, the general surgery people do laparoscopic endoscopy, abdominal endoscopy. OB does pelvic endoscopy. The Euro people will do bladder and ureter endoscopy. So they're used to the endoscope. But in orthopedics, of course, it's a small scope. So it's different from what other specialties use. So it's a matter of getting used to that. Also a matter of getting used to the irrigation. This was initially a big problem for me when I started. The nurses could not comprehend sometimes why you have to keep the water running, why you have to keep replacing the saline packs and not let it run out of water, because when the pressure drops, everything starts to bleed. And it takes them a while, it takes them a few surgeries before they get used to the idea that they have to keep watching the water level. And later on, they eventually learned it, so I normally don't have a problem now with my irrigation system. But in the beginning, they couldn't immediately grasp it. It's different from from laparoscopic surgery, because in lap surgery, they pump in the gas, and usually the nurses don't have a problem with that. The gas just keeps coming, the CO2 just keeps coming. It's different when you have saline solution, 1 liter bottles that you have to replace every time. So the goal actually, if you notice, of all these endorsements that I'm making, is to get everyone, the surgeon as well as the OR staff, get everyone used to assisted visualization, to minimally invasive or percutaneous procedures using devices. You're basically like playing a video game. Your two hands are moving independently. You're looking at a screen. You're not using your bare eye, so you don't have stereoscopic or 3D vision. You're actually looking at a two-dimensional vision on the screen. And you have to get used to that as you move your hands without actually needing to look at the operative site. You can't even see the actual operative site because it's under skin. And you can't see the tip of your instruments because it's under soft tissue. So you have this takes getting used to, but with practice, you can actually get to it. For hand-eye coordination, one of my senior orthopedic spine surgeons was asking me, how do you, because he's not used to doing biportal endoscopy, he was asking, how do you do that? I said, sir, one of the tips I can give, play a lot of video games. You'll get used to it as you go along. Moving your hands, looking at the screen, etc. Having two different movements for your left and your right hand. Okay. So, this is an endorsement that this is something I learned from Dr. Bustillo as a resident. Drawings. I have noticed that some of the spine endoscopists like to draw. Not all of them showcase it, but definitely those who are very active in teaching, in doing surgeries, also share a lot of drawings. And I guess we like doing drawings because if you're dealing with something endoscopically, it's sometimes hard to imagine. One of the best tips that I learned is that if you want to see whether you already understand the anatomy, try drawing it. Because if you can draw it, then you probably know it. It doesn't have to be a very beautiful drawing, as long as you can draw it anatomically correct. So that's okay. So if you practice drawing it, then it starts to become more and more automatic in your head, even if you don't get to see the entire big picture. It's an example of an operative technique form that I used to do when I do fusions, for instance. I like doing the drawings because my handwriting is bad, so I might as well just draw it so that people understand. It's a very good way to also to help the OR staff, even the hospital, understand what it is you're doing, because then they see in the technique, oh, okay, this was done. Especially if you draw the before and the after image. Okay, now that I'm doing endoscopy work, I draw the pre-operative and the post-operative schematics of what I did. So, but I enjoy it. I'm getting better at it as I go along. One of the nice things, one of the benefits of having started this is when I went to Korea, Dr. Cholbong Park basically asked me to start drawing for him for instructional purposes, and I ended up doing freehand drawings. Some of them I feature in my videos, and it's actually challenging to try drawing it, but I ended up drawing step by step illustrations of how to do the approach, do your opening, you know, how to do the tissue dissection, etc. It's a very good training. You're not doing the actual endoscopy work, but you're also learning while you're doing the drawing. So you don't have to, of course, be an illustrator, but it does help to make the effort so that it burns into your mind how the anatomy looks like. Okay, so moving on. This is a big issue. I've actually sometimes had disagreements with this with other doctors here in the country doing video documentation. You know, this is a day and age of the internet, of computers, of social media, and a lot of things go on the internet. If you search, for instance, YouTube, you will see a lot of surgical videos, educational surgical videos that feature the actual procedure. And there's nothing wrong with that in reality. But for some reason in the Philippines, a lot of surgeons actually fear having to display what they do. I'm not sure exactly why. I can't understand it myself, but I've always been an advocate of being able to highlight what you do, document what you do, and later on present it. Of course, we do that during conventions, but for my own practice, I've been doing video recording for since around 2011, and I've been in the habit of showing my pictures, my videos to my patients, both the ones that I just operated on as well as the ones who are still for operation. I find the instruction, the teaching of patients using actual videos to be empowering. They like it because they learn from it, and then they can make better decisions because of it. This is an example. This is a patient whom I just did an ACDF on the day before. He's doing fine. Single level ACDF, nothing spectacular about it. I'm sure a lot of you have done this. But you know, after during the night, I re-edit the videos that I took in the OR, and then the next day I present it to him and his wife over here, and I show it to him and make him review it. And I actually ask him, can I feature this for as a teaching video in my YouTube channel? I will, of course, protect your privacy, your anonymity. I just like to show the technique. And you'd be surprised that a lot of patients actually like having their surgical techniques featured. And sometimes they'll feature it themselves, and they don't, you know, they won't bother with keeping their anonymity. They don't mind. Some of them don't mind anyway. Others, of course, will still want the anonymity. But the point is, if you ask them nicely, they will definitely give you permission. Some of them will do it themselves. So the whole idea of data privacy is not compromised with the goal of being able to teach and share what you do. This is one of the patients that I did minimally invasive shoulder surgery on under blocks. So he was fully awake during the surgery, and outpatient surgery. I discharged him immediately. And in the same afternoon, you know, just maybe an hour later, he basically posts and tags me in his Facebook showing the picture that we had in the OR. So it's not really a big deal, as not as a big deal as some doctors might think. If you just ask nicely, if you follow the rules of informed consent, patients will indulge you in it, and you can teach them more, and you can teach more patients in the future. Okay, I like to. I used to teach this to my students. I keep telling them, you know, you want to be a doctor. Do you know where the term doctor comes from? It's from the Latin verb docere, meaning literally to teach. So I think one of the obligations of us as doctors is to learn how to teach correctly, especially patients. Okay, having said that, having gotten into the topic of using videos to teach our patients, it would be nice to share what we actually go through. And then, like this webinar, for instance, this conference, conventions that we do, it's all about sharing. And this is actually a very welcome thing, especially in this day and age that we have good information technology. Uh, I bothered to search just today in YouTube. I was thinking, how many people in the Philippines, in my country, feature their surgeries online? And I searched for this term, orthosurgery Philippines, and actually I couldn't find much of anything except for a few documentaries on hospitals, etc. One thing I found was this. This is by a mentor of mine, Dr. Rafael Bundok. I don't know if you remember him. He was the chairperson of the 5th ASEAN MISST Congress 2 years ago. He had this video on minimally invasive on endoscopic surgery, spine surgery. He's a very respected, esteemed mentor of ours in the Philippines, one of the greatest spine surgeons, I think, in our country, one of the greatest teachers I've ever had. But aside from his video and maybe my videos, I don't know who else does this. You do a search for surgical orthopedic procedures, you will see a lot coming from, say, Korea, or coming from India, or coming from even your country, Egypt, or any of the other Middle Eastern countries. Definitely coming from the U.S. or Canada, or the European countries. So there are a lot of doctors who feature the work that they do, the techniques that they have. They share it on the internet, and I'm wondering why we don't have a lot of this in the Philippines, considering that social media is a very big thing in the Philippines. A lot of the Filipinos are connected on the internet, including doctors. We're all over. We're on Facebook. We're on YouTube, etc. So how come we don't see a lot of orthopedic training videos? I don't know the answer to that just yet, but just to share that particular thing with you, it's good to be able to share it on social media, within, of course, but without disrespecting the patient's privacy and the patient's right to informed consent. Okay, well, one of the things my father taught me: you can't give what you don't have. One of the nicest things with thinking that I will teach, I will share this with other people, is that it's a good motivation for you to learn more. Because of course you can't share much if you don't know much. So it drives you to actually learn a lot more, to learn better as you go along, so that you have something worthwhile to share. That's the whole point. So I think by engaging in these practices, if you're in the habit of sharing something new that you discovered, or some new idea, good idea that you have, it reinforces itself. You try and teach it, you try and share it, so it convinces you, it motivates you to learn more. You learn more, so you have more to teach. You have more to teach, therefore you try and learn more. So it's a positive cycle. It's a reinforcing cycle in itself, and it's a very important thing, I believe, for us surgeons. This is an example of one of the playlists I have, the endoscopic playlist for my YouTube. I've featured a number of them. I haven't done that many yet, but it's a joy to actually do a video that wherein your objective is not just to show the technique, but to be able to teach it to maybe somebody else who would like to try it, or who would like to go into the same thing that you're doing. So it's a challenge, but I think it's worthwhile taking this challenge. One of the things that I do observe with spine endoscopy, one of the things I love about it, is that it's so easy to share, because the material that we have is already digitally recorded. The endoscope machine can record the video easily. You probably don't think much about it, because it's an automatic thing. The machine will record, but you have so much video data that you can actually share and use for teaching. And a lot of endoscopists actually do this very routinely. They do a technique, they record it as usual, and then they edit it, and then they share it and use it as a teaching file. It's a lot easier when it's endoscopic, because you have the machines. So as long as you get the patient's consent, the patient gives you the permission to share material, then there's nothing really stopping you from being able to share. I noted that spine endoscopists are some of the most generous surgeons that I've ever met as far as sharing surgical technique goes. And not even the pandemic could stop this sharing, because even in 2020, when COVID was raging, and even in here now in 2021, when the incidences were coming back up again, everywhere people were doing webinars, were doing conferences online. And it wasn't a big issue doing a conference online, because it's easy to share the digital video format if you're doing it online. They easily put together conventions everywhere, and they would ask people, would you like to attend? And it's so nice, because you see how other people handle these problems, and it makes the evolution of the techniques, of the technology, much faster. I know we're used to sharing, or we're used to looking at our data scientifically in journals, but this is sort of a shortcut way of doing things, because now you immediately see how things are being done. Okay, that said, a few obstacles. These are just a few, but they are very significant as far as my experience goes. A few things that might discourage the both the surgeon as well as maybe the hospital in adopting endoscopic surgery techniques. One of the earliest things that I ever heard was that It's either, you know, the hospital will say, oh, we're not capable of doing this. We don't have the staff, we don't have the equipment to do this. Or sometimes even a doctor or a few doctors will say, I don't want to learn it. I don't think I can do it. So it would be tragic if that's how people think, but it's actually a lot easier to set up than most people might think. Okay, I would say that if you want to do this transition, it's quite easy. You buy what you can as far as the equipment goes. You use what you already have, and you know, without you realizing it, you already have a lot of stuff that you will need. And then for everything else, you can improvise within the bounds of safety and reason. Of course, you improvise for as long as it doesn't compromise the patient's safety. One of the pictures I took in one of the nurses' stations, chart with order. Somebody thought of fixing this tape dispenser this way. Very good improv, crude, but it works. Improvisation. So initially, in the beginning of my practice, I was trying to improv on certain aspects of how I do the surgeries. Since my initial exposure was with Dr. Daejun Choi in 2019, he loved using osteotomes in doing his work. He would do his endoscopy, detach the muscles, chisel away at the lamina, and do everything basically using osteotomes and curettes. And that's how I initially learned it. But you know, the set that he brought with him, this is a very nice instrument set, including the arthroscope, including the K-punch, the rotating K-punch. This is very expensive by Philippine standards, and you're going to be lucky if the hospital will buy this for you. Usually in the Philippines, the surgeons normally buy their own instruments. And so because the instruments are usually made abroad, they are quite expensive and can be prohibitive. But you know, if you know how to use an osteotome like this or a curette like this, then you don't have to necessarily have the set. You can build your own set from locally available brands. So that's what I did in the beginning. I made use of osteotomes that were already available in my country, in my setting, curettes, etc. I would use a periosteal elevator to do the muscle detachment, etc. So that's how I started my practice in this. Okay, how about ablators? This is a...
We are out of time, sir.
Oh, sir. Okay, sir. I'll wrap this up, sir.
Okay, thank you.
Okay, so just to wrap it up, I guess this is one of the innovations that I did, bipolar cautery. If you can repurpose certain instruments, you can do that. And that just to show you a view of how I've been using this. Okay, I'll skip that and all the others. The burr. The burr, sometimes when my old arthroscopic drill would break, I can use this burr. Does the same job. I'll skip this. Scope. Just one last thing. I recently did the surgery in a far-flung province. There was no endoscope tower. I made use of a scope that can be connected to a computer. It's high definition. It has a portable battery for light, and you can basically do your surgery using that. So it's actually not that impossible. Sometimes it feels like this. You're trying to suggest something new, but other people think it's not effective. It is. Just a few papers that I've been amassing. I hope I can share that in the future. So take-home messages, especially now in the time of COVID, minimally invasive surgery, very useful in lowering the cost, especially in this economy. A great way to avoid needing to use instrumented fusion. Patients are very satisfied with it. We have the data to prove that. And of course, in a setting where affordability is a great concern, yes, that's good. COVID exposure, also a very big plus, because if you're doing minimally invasive surgery, if you're not doing intubations, if your patients are having their surgeries done outpatient basis, you reduce risk of actually spreading COVID around. So this is our experience here in the Philippines so far. That said, oh, I'll skip this, sorry. Never mind this. I'll skip this from here, and I hope that was good enough for you. Thank you very much for your attention.
Thank you so much, Professor David Henry, for this marvelous presentation. Thank you so much, sir. I think Professor is with us now.
Okay, thank you very much.
Your presentation, sir?
Yeah, I try again. Sorry.
No problem, sir.
Can you see the slide?
Yes, sir.
Okay. Sorry about that. Okay. My topic is endoscopic extremity surgery for large cage. focused on UB surgery, I'd talk about the history first. UB is modification of a translaminar lumbar epidural endoscopy. 1996, the Anthony D first published this article. And this is original article. In 2001 February, Abdul Ghaffar presented about this technique at AAOS San Francisco. According to the first article, 1996, this translaminar lumbar epidural endoscopy was done lateral position. So that we changed it, we applied radiofrequency device and changed it from position, and we made the proper instrument. So 2003, I presented about this technique, Korean Japan conference, and during 10 years, we collected data and established our UB technique. 2013, I presented about this technique in Sapporo, Japan. This is 2016, January. This is the first UB article, percutaneous biportal endoscopic decompression for lumbar spinal stenosis with Dr. Ho. And now, I will talk about the endoscopic extreme TLIP surgery. So impossible battle, as you know, if the this kind of large cage or leakage under the, we can put a Orly cage into the interbody space under the endoscopic TLIP procedure. Is it possible? I will show you. There are various surgical approaches for lumbar interbody fusion, as you know, PLIP, TLIP, and XLIP and OLIP are lip. For better spine fusion, precise and gentle end-plate preparation is essential, and large interbody spacer will be fine. Okay, a proper cage position for balance is also very important. So we can use bone materials, DBM, BMP, or I-factors. For good coronal and sagittal balance, we have to follow 3 rules. PI-LL mismatch should be less than 9 degrees, SVA 5 cm, and PT 25 degrees. For following this rule, cage size and cage position is very important. So TLIP cage its width is 11th and 13th, and the length is 28 and 32. Some company made 38 millimeter. But XLIP and OLIP cage is width is 18, 20, and 22. Length is 40 and 45, 50 millimeter. So in the picture, OLIP cage is very big, and we think the bigger would be better. Also, cage position is very important. Alexander published the article, the center of end plate is the weakest part. Endoscopic TLIP surgery, in the picture, you can see the cage is well positioned, but the cage position is the center of the end plate. So good cage position should be like this. In the AP view, the cage should be lie from pedicle to pedicle, and lateral view, the center of a cage should be anterior to that of a spine body. For better fusion and correction, OLIP and XLIP surgery is better than the TLIP and PLIP surgery, I think. So I tried OLIP surgery, but OLIP surgery have this kind of disadvantages. Vascular injury, sometimes very fatal, and spastic chain injury, urinary tract, peritoneal injury, and also not so easy technique for ordinary spine surgeon, especially in L5S level. And indirect posterior decompression, also we cannot use autobone. For posterior decompression, we need to change position. But recently, some surgeons can do this job in lateral position, but it is not easy technique. So under TLIP procedure, if I can put a large cage into the interbody space, this kind of procedure will be better, I think. So I reviewed the Cambridge triangle, 2016, Reed, according to the Reed cadaveric analysis of the Cambridge triangle, L3 and 4, the base is 17 millimeter, and L4, 5 is 18 millimeter. So I have to make EX TLIP operative collider. I removed facet joint completely and extended Cambin triangle. I call it LEK, length of extended Cambin triangle. So length of LEK, length of extended Cambin triangle, and L34 is over 17 millimeter, and L45 over 18 millimeter. And L5S1, there is no data, but facet joint is very wide. So possible width of cage should be 18 and 20 and 22 millimeter. This is examples of preoperative measurement. I always check the LEK before operation in the MRI. At L4-5 level, the average is 18 or 20. L5S1 level, the average is 19 or 23. So this is the picture of an endoscopic procedure. You can see the operative corridor is enough, almost 20 millimeter. So we made an EX TLIP procedure, endoscopic TLIP and total facetectomy with large cage. The size is same as only cage and transverse line of cage. Operative route is between the TLIP and XLIP. So indication of XLIP, EX TLIP is the same as those of TLIP surgery. I will show the cases. 65-year-old male patient, low back pain with lateral radiating pain. Already 6 months before, he did endoscopic surgery but failed. In the MRI, you can see the L5S1 level, foraminal stenosis and the lateral recess stenosis. And this is a picture of the endoscopic view, and the preparation is relatively good, and we can get enough autobone. This is actually transforaminal approach at L5S1 level. Already I removed the facet joint completely. And the annulus of the disc annulus is hard, so I have to use the calcium plunger. And you can see the L5 exiting the root cranially. Surgical procedure is the same as minimally invasive TLIP surgery. I put the shaver into the L5S1 distal space. And after plate preparation, we can put the Orly cage under the endoscopic control. So this is L5S1 level. Post-operative X-ray, we can see the cage in the AP view. The cage is laid from pedicle to pedicle. In the lateral view, the center of the cage is not so satisfactory, but rhodotic curvature is relatively good. This is post-operative MRI. Decompression was done completely, and cage position transverse line is very good. The next case is 75-year-old female patient with low back pain with lateral radiating pain, diagnosed as spondylolisthesis L4-5, and post-operative MRI showed the cage position is very good, and nerve was decompressed very well. And this is actually a paramedian approach. The procedure is the same as TLIP surgery. We have to remove the lamina and facet joint completely. After removing a facet joint, we can get into the L4-5 discal space. You can see the exiting nerve root and the transverse loop root. And we can put the shaver into the interdiscal space and the retraction of the medial transverse nerve root. Then you can try trial. This is width is 18 millimeter. And under the cage guide, we can put the only cage into the L45 interbody space without nerve root damage. And then we try to lie cage transversely line. So the root is not damaged. Case 3 is very interesting case. 75-year-old female patient, low back pain and right leg radiating pain. She has schwannoma L45 and spondylolisthesis L45. Preoperative MRI, you can see the schwannoma L45 level. And I did the microscopic removal and exactly L45 level. The cage is located well. And this is a picture of microscopic surgery. So I'll give the tips for proper procedure. Usually, I recommend unilateral modified swab to osteotomy for proper reduction and transversal lying of large cage and anterior distraction and posterior contraction. These three factors are necessary for reduction and for coronary size type balance. Advantages of EXT-LIP is we can do direct decompression, and we can do reduction, and we can get a coronary size type balance, high fusion rate, low subsidence rate. We can avoid vital organ injury. Also, this surgery is spine surgeon friendly procedure, so no need for backup vascular surgeon. Complications may be the same as those of TLIP surgery, but early learning stages, the complications is higher than expected. Disadvantage of EXT-LIP, also technically demanding procedure, and we have to worry about the root damage, a minimal procedure, but still posterior approach. Present status, 2019, December, more than 10 hospitals in Korea. Now we did over 200 cases. So first EXT-LIP article was published 2021, 19th February, modified bilateral endoscopic transforaminal lumbar interbody fusion with Dr. He. So EXT-LIP is a possible mission. We can put only cage into the interbody space under endoscopic TLIP procedure. Conclusions. EXT-LIP procedure provides larger interbody fusion bed and space compared to those of TLIP surgery. I think bigger cages would be better, but further long-term study is required. Thank you for listening.
Thank you so much. Thank you so much, Professor for this very interesting talk. If we have any questions to Professor Okay, we will move to the next speaker. The next speaker will be Professor Mohammed Abdelwanis from Sohag University, Egypt. A little bit different topic. He will not speak about the spinal endoscopy, but it will be another topic, which is thoracolumbar fractures. Professor Abdelwanis, you are with us? Thank you, sir.
Yes. Do you see my slides?
Yes, sir.
Yes. Thank you, Dr. Muhammad, for this kind invitation, and thanks for giving me the chance to be listening also to this distinguished faculty presenting their work. My talk is directed to our postgraduate students who will pass the master degree exam or the doctoral degree exam, and will not be sophisticated or advanced. It will be basic talk about the dorsolumbar fractures. The old concept since the 1968 is that the spine is formed of two columns, the anterior column and the posterior column. According to this principle, the posterior column is formed of the posterior longitudinal the fast joint capsule, the supraspinous ligament, and the interspinous ligament, while the anterior column is formed from the vertebral body, the anterior longitudinal ligament, and the annulus fibrosus. According to this concept, the fracture is considered unstable if there is injury of the posterior column, unless the Dennis presented his three-column theory. Dennis divided almost the anterior column into anterior and the middle column. So the anterior column is formed by the anterior part of the vertebral body, the ALL, and the anterior part of the annulus. The middle column is formed of the posterior part of the vertebral body, the posterior part of the annulus, and the PLL. And the posterior column is almost the same like our old concept. The principle that pushed Dennis to present his philosophy is that he considers that the integrity of the middle column is the key anatomic determinant of stability. However, although Dennis' concept is accepted by some spine surgeons, yet others don't accept this concept and don't consider that any fracture of the middle column is considered an unstable fracture. Coming to what is the definition of spinal instability? The spinal instability is loss of the ability of the spine under physiological loads to maintain relationships between vertebrae in such a way that the spinal cord or nerve roots are not damaged or irritated and deformity or pain doesn't develop. This is an old definition, however, it's still working. Coming to the causes of the fractured spine, any forces which tend to flex the spine plus minus rotation might cause a fracture of the spine, like falling from a height, or motor car accidents, or blows across the back like in mining. Any of these mechanisms of injury might cause fracture of the spine. According to the old classifications, we have similar classifications actually. I will present these two famous old classifications because they will help us to understand the pathomechanics of the fracture. There are minimal differences I will show you. According to McAfee, there is wedge compression, which is compression in Dennis classification. In McAfee principle, not all fractures of the middle column are unstable. So according to McAfee, there is a stable burst fracture and unstable burst fractures. However, according to Dennis' concept, the burst fracture is necessarily unstable and it is only one category, not like according to the McAfee classification. Chance fracture is the seat belt injury in Dennis' concept, and the flexion distraction and the translational injuries in McAfee classifications are considered three items in Dennis classification: flexion distraction, shear type, and deflection rotation. Coming to the McAfee, I will use it in this short talk. It is formed of these 6 types: wedge, stable, stable burst, unstable burst, chance fracture, flexion distraction, and the translational injuries. What is wedge compression? Wedge compression is failure of the anterior column under compression. So the anterior column is compressed, or the lateral, there is lateral compression, the vertebra is compressed laterally. According to this concept, the anterior column is fractured, so the posterior wall of the vertebral body is intact. We mean that the spinal canal is not jeopardized. There is no injury there is no possible injury for the neural elements present here. Coming to burst fracture. Burst means explosion, as all of us know. In Arabic, it is infigar. How would this fracture occur? This would occur if someone falls from a height, and strike against the ground. So the force applied to the spine will come from above, and the ground will reply by another force equal in amount, in magnitude, and the reverse in direction. So the vertebral body is compressed between two forces, and this leads to explosion of the vertebra with exploded fragment coming to the posteriorly to the spinal canal. So coming to the if we can understand the criteria, the concept, the mechanism of injury, we can understand what we will find in the X-rays and in the tomography, in the tomogram and in the CT. There is fracture of the posterior vertebral wall, fracture of the posterior wall of the vertebra. There is a retrovulsed fragment. This fragment is retrovulsed inside the spinal canal, and there is increase in the interpedicular distance because the vertebra is exploded. Usually, the width of the interpedicular distance increase from up downwards by 1 millimeter maximum. Usually, it is equal or wider than 1 millimeter than the higher one. And you can see here that this is interpedicular distance is wider. And we may have fracture of the posterior neural arch. So in this case, there is laminar fracture. If we can understand this, we can diagnose very easily the burst fracture in the X-rays and in the CT. Coming to this, it is clearly burst fracture with a retrovulsed fragment inside the spinal canal. According to McAfee, there is unstable burst fractures and stable burst fractures. The unstable burst fractures are those associated with subluxation of the facet joint, fracture of the neural arch, gross displacement of the neural elements. And this is his primary concept published in 1983. Other surgeons defined another criteria, like more than 50% axial compression, more than 20-degree angular deformity, multiple contiguous fractures, neurological injury, so 3-column injuries, and more than 50% canal compromise at L1 and 80% at L5. These are the criteria according to McLean presented in 2001. Again, this is if the surgeon believes that not all burst fractures are unstable. However, a very important question. We, for a long time, were depending on the X-rays for diagnosing burst fracture. Is it sure? Is it accurate? This paper published in 1992 showed our results in the diagnosis of burst fractures by X-rays. In 45% of the burst fractures in this study, there was no increase in the interpedicular distance. In 41%, no loss of partial cortical of posterior cortical height, and neither of both were present in 14%. This means that routine use of CT is needed in all patients with compression fractures because we may easily miss big number of burst fractures and underestimate the severity and classify the fracture as compression fracture while it is truly a burst fracture. Coming to chance fracture. Chance fracture is failure of both the posterior and the middle columns under tension while the anterior column is intact. How would this fracture occur? This fracture would occur if someone is in a car going rapidly and have face-to-face accident, so that his body will move forward, limited by the seat belt. The trunk will bend depending on a point at the anterior abdominal wall, which is the site of attachment to the seat belt. In that case, the posterior column will be tensioned, will be stretched until the force is causing failure of the posterior and the middle column. Because the point at which the trunk flexes is at the anterior abdominal wall, the anterior column is intact. And this is very important criteria to differentiate between the chance fracture and flexion distraction injury. The anterior column is intact. This chance fracture is through the bone. However, it might occur through the disc and through the soft tissue. And like you can see here, this is a case from the literature. As you can see here, this X-ray looks normal as regards the bone. But if we have a look to the posterior width of the disc, you can easily recognize that this is the picture. This is a chance fracture through the soft tissues, and this is an unstable injury, and it may be missed if the surgeon had a look only to the bone. And also the chance fracture may go through two vertebrae, like this case. As you see here, you can diagnose it easily from the lateral view. However, from the AB view also, you can diagnose it easily. Look to the distance between the spinous processes. Look to this distance and look to this distance. It is very easy to recognize that in the AB view, in the chance fracture, the space between the spinous process, interspinous space, is increased. Also, MRI might be indicated if there is suspicion for this ligamentous and soft tissue injury. And as you see here, there is soft tissue injury definitely, and you can diagnose this patient as chance occurring at soft tissue. And you can see here also this line through the bone. Coming to flexion distraction injury, that has a great resemblance to the chance fracture with some difference. If you have a look to this fracture, how would this fracture occur? The body is bent with a point is a fulcrum at the anterior wall of the vertebra. So in that case, the body will flex like this. With flex like this. This means that the posterior and the middle will fail in compression. If the anterior column is widget, this means that this is a flexion distraction fracture. This is a flexion distraction injury, as you see here. This is a horizontal fracture of the posterior arch, and there is interspinous widening. This is different than this. Of course, translational fracture is very easily to be diagnosed, like this. This is malalignment of the spine. Coming to the AO spine classification, which is now very widely globally accepted, it depends on three criteria: morphology, neurology, and case-specific modifiers. The morphology divided the fracture into A, which is failure of anterior structure under compression; B, which is failure of anterior or posterior tension band; and C, which is displacement or dislocation. It is increasing in severity, means that A is more benign than B, and B is more benign than C. Coming to the A is either A0, which is minimal fracture, not disturbing the spinal canal, not affecting serious structures, and A1 is compression fracture of single end plate, like upper end plate or lower end plate. A2 is coronal split fracture, both end plates. A3 is typical burst fracture, but one end plate. A4 is burst fracture, both end plates. What is B? B is either B1, which is bony posterior tension band injury. This is a typical chance fracture. B1 is a typical chance fracture. B2 is typical flexion distraction injury. Bony and or ligamentous failure of posterior tension band, the type plus type A fracture. As I said, in flexion distraction, there is fracture of the anterior column. So this is B2. And when we call this fracture, we call thoracic 12 L1 type B2 with A4 fracture of L1. So this is L1. This is L1. There is A4 if there is fracture of both end plates, or if it is one end plate, it is A3. I'm sorry, it's A3. And it is thoracic 12 L1 type B2 fracture. And this is how we express this type of fracture. B3 typically occur in ankylosing spondylitis, or in cases of ankylosed spine with hyperextension injury. C is any fracture with translation or displacement in any axis, like in any direction. The neurology is divided into N0, this means intact; N1, transient deficient, and currently the patient is neurologically free; N2, radiculopathy; N3, incomplete cord injury; and N4, complete cord injury; and NX, undetermined because the patient is comatose or disturbed level of consciousness, and the neurological evaluation is impossible. The case-specific modifiers in the lumbar spine is either M1 or M2. M1, intermediate injury to tension band if I'm not sure if there is injury of the tension band, soft tissue, or not. In that case, I will put M1 so that the listener, the colleagues recognize that I am suspicion about the ligamentous injury, and M2 critical comorbidities like osteoporosis, like ankylosing spondylitis, or diffuse idiopathic skeletal hyperostosis. What are the complications of fracture of the spine? Neurological deficit, which is the commonest cause of spinal cord injury, bowel and bladder complications, DVT, pulmonary embolism, spinal deformity, bed sores, and pneumonia. It is important to search for sacral sparing before classifying any neurological injury as complete, because the only intact neurology the patient has might be a sensation around the rectum, around the anus. This means S3, S4, S5 nerve root intact, or back to flexors. This will change the classification of the patient from complete injury into incomplete injury. The patient might be presented to us with a stage of spinal shock, uh, uh, defined as total loss of motor, sensory, and reflex function of all segments following a cord lesion, usually transient, lasting from hours to weeks. The end is demonstrated by return of the bulbocavernosus reflex or anal reflex. How we make the decision in cases of thoracolumbar spine fracture? Depending on the most important factors are neurology and stability. Our goals of treatment are to restore or maintain the neurological function, to prevent or correct segmental collapse and deformity, prevent spinal instability, permit early ambulation and return to function, and restore normal spinal biomechanics. These are the goals of treatment of spinal fractures. First aid measures are very important. I always begin by it. I begin by number 2 because number 1 is very important, and I will show you now. When fractured spine is suspected, the patient must be handled as one segment, like this. I have 2 of my patients presented to me with complete neurology, while immediately after the accident, the patient was neurologically free. Neurological injury occurred during transportation of the patient. And this is a very big catastrophe. So when fracture of spine is suspected, the patient must be handled as one like this. Avoid unnecessary movement, transport the patient on a stretcher, treatment of associated injuries, and do anti-shock measures. The conservative treatment by different methods, bed rest, plaster jacket, or corset, indicated in stable fractures with no neurological deficit. The indications of surgery are spinal instability or neurological deficit due to compression. If the patient is incomplete neurologically, hoping for improvement. If the patient has complete neurological insult, the aim is for easy rehabilitation. Principles of surgery: decompression, restoration of alignment, and fixation. Maybe fusion. Some recommend fusion, some do fusion, and some don't. The surgery might be through posterior, anterior, or combined. Combined might be posterior anterior or posterior lateral. What I can do through the posterior exposure: instrumentation, decompression, and anterior reconstruction and fusion. This is the decompression, either direct by doing laminectomy or indirect by ligamentotaxis. How we do this? Insert the screws and then apply compression, and after restoration of the height by distraction, tighten the screws. In that case, we indirectly decompress the spine. The spine instrumentation might be short segment or long segment. This patient is one of my patients. Male patient, 26 years old, fell from a tree, thoracic 4-5 type C with thoracic 5 type A4 and N4. The patient complete paraplegia. This is the CT, and this is post-operative, and this is a lateral view. For these patients with complete neurology, I usually do wide decompression for medical legal purposes, and in the other other point is that this is in the thoracic spine. I am not afraid about losing motion segments, so there is no problem to use long segment. This is a L1 burst fracture, and this, as you see here, is I did short segment fixation because I don't like to lose motion segments in the lumbar spine. The patient had a full restoration of the vertebral height by ligamento-texas. This is a A4 fracture, L3, N0, neurologically free burst fracture. And as you see here, this is the short segment fixation. However, one of the complications of short segment is high incidence of metal failure reported in the literature in varying incidence from 9 to 54%. This is one of my patients. How to add to the stability if we use short segment? Use crosslink. This is one of my patients, thoracic 12L1, type B2. This means this is a flexion distraction injury. L1, A3, this means burst fracture, one end plate. N0, this is neurologically free. And this is, as you see here, there is flexion distraction and the anterior column is compressed. So this is flexion distraction fracture. And this is the after fixation. And I put cross link because I am not satisfied with short segment fixation in this patient. And at the time, I was believing this is a very old case, and I was believing that the cross link will add to the stability. Nowadays, I will never do that with any case with flexion distraction injury. I used long segment fixation. Coming to this paper published in 2013 discussed the use of X-shaped crosslink in posterior spinal constructs improves the stability in long segment fixation in thoracolumbar burst fracture. However, from the finite element method, this study showed that crosslink did not improve the stability when a short construct was used. So if there is fixation by short segment, this crosslink is not adding to the stability. How to add a screw in the fractured vertebra? This is one of my patients, female, 30 years old, thoracic 12, type A3, N0. This is incomplete burst and neurologically free. As you see here, A3. And this is after adding one screw to the fractured vertebra. Coming to the literature, biomechanical comparison of short segment posterior fixation, including fracture level, including fracture model. This study proved that short segment posterior fixation, including the level, has comparable stiffness to that of circumferential fixation. So actually, I recommend always to add at least one screw in the fractured vertebra if this is visible. But if this is suitable, is this suitable for all patients? This study in 2016 suggested that short segment fixation with intermediate screws is a viable technique with positive clinical and radiological outcomes at 1 year follow-up. However, surgeons should be aware that in obese patients above body mass index above 30, this technique is associated with an increased risk of loss of kyphosis correction. So if you have a same patient, you can get good stability by short segment fixation with a screw in the fractured vertebra. However, if the patient is obese with a body mass index more than 30, this is risky and may be associated with metal failure. Of course, through the posterior exposure, we can do corpectomy and we can insert this cage. This is not my case. We don't have distractable cage here in Egypt. It is very expensive. And this is from the literature. And in that case, we can insert this cage and distract and do anterior and posterior fusion through a single posterior approach. The anterior exposure can be used also, and anterior instrumentation with insertion of cage or iliac bone. The combination surgery might be indicated in some patients, like in this patient with severe Barrett L3, and this patient has also ligamentous injury posteriorly. This is a three-column injury. As you see, this patient was treated by outside Egypt. This is by distractable cage and posterior instrumentation, anterior and posterior fusion. And also, this can be combined by posterior and lateral exposure. This is a patient was operated in our department, female patient, 17 years old, L3 fracture, A4, N0. We did the surgery in two stages, posterior instrumentation with short screw inserted in the fractured vertebra, and then through the lateral exposure, through 2 weeks later, we inserted iliac graft, as you see here, achieving both anterior reconstruction and posterior fusion through, in two stages through posterior exposure and lateral exposure. The treatment of traumatic paraplegia either by steroids, as we all know, methylprednisolone as a bolus, and then followed by infusion. However, limited number of centers are still using steroids in cases of spinal cord injury. This period, mobilization in bed, prevention of joint deformity, care of the bladder and bowel enemata, and rehabilitation. So my take-home message is, Barrett fractures, which are A3 and A4 in the AO spine classifications, show increased interpedicular distance, retropulsive fragment, and the fracture of the posterior vertebral wall. Chance fracture is B1 fracture, may be through the bone or the disc. In chance fracture, the vertebral body is intact, while it is wedged inflection distraction injury, which can be called B2, A1 according to the AO spine classification. Indications of surgery are spinal instability and neurological deficit, and surgery might be posterior, which is the commonest, anterior, or combined. Thank you.
Thank you so much, Professor Mohammed Abdulanis, for this very interesting talk. If anyone has questions, he can write it in the box of question answers. We are waiting for any questions to Professor Abdulanis. Any questions to Professor Mohammed? Okay, now we will move to the next speaker. The next speaker will be Professor Mohammed Fawzi Khattab from Ain Shams University and the head of AO chapter, AO spine chapter in Egypt. Congratulations, Professor Khattab, for this achievement.
Thank you so much, Professor Mohammed Al-Ashhab. I'd like to thank the Orthopedic Department in Banha University for their active spreading the knowledge all over the world. Of course, this is a great achievement that you did today, that McMaster University applied your course on their training. Thank you so much for inviting me, and I'd like to thank the Egyptian Orthopedic Association for their cooperation, as well as Banha Orthopedic Department. My talk today about derotation technique in scoliosis surgery. Scoliosis is a three-plane deformity: coronal, sagittal, and axial deformity. And our goal is to prevent the progression with fusion. Of course, achieving the maximum correction, fusing less level, ending by balanced trunk. Vertebral rotation can be seen clinically when the patient lean forward by Adam forward bending test. We can see the rib hump, as we can see in this clinical photo of one of my patients. And the presence of rib hump indicates that there is more than 30-degree rotation in the vertebral body. The plain X-ray can help you to see the rotation as well, either by checking the ribs, which are unequal inter-rib spaces, or by detecting the Nash-Moe method, where you can bisect the vertebral body into two halves, and where the convex pedicle is present, either in the outer or in the middle or in the inner thirds of this half, because with scoliosis, there is a rotation. The convex pedicle appear more and the concave pedicle disappear. In general, we have 7 correction maneuvers to correct scoliosis: compression distraction, simple rod rotation, simultaneous double rod rotation, rod translation maneuvers, direct vertebral rotation, cantilever bending, vertebral coplanar alignment. All these are correction maneuvers. Today we will focus on the 3D direct vertebral rotation. But I'd like to tell you that correcting the 3 planes is mandatory in the deformity, and we need to be quick, safe, and simple, and apply less stresses to the patient and the implant. In order to correct the coronal plane deformity, we need to do compression distraction. Of course, compression on the convex side, distraction on the concave side, and this was applied by Harrington rod in the past decades. Rod translation: when you put the rod in the desired plane, then you translate the spine to the rod by sublaminar wires. For example, cantilever bending can be applied to correct the coronal plane by putting the rod in the designed sagittal profile, apply it in the proximal construct, then try to cantilever and put the rod inside the screws. This is help to correct the coronal plane deformity, or incito bending by the coronal incito benders, like we can see here in this clinical photo. We can use the coronal incito bender to translate the spine to the midline. Sagittal plane correction, rod rotation technique can be applied as we do in the anterior scoliosis surgery. Double rod rotation, which was applied by Cotterell Dubussy in 1991 to correct the sagittal plane by transferring the deformity from the coronal plane by the well-contoured rod in the coronal plane to correct it and correct the deformity. Axial plane correction, our direct vertebral rotation technique, is a 3D correction of scoliosis. It is a true rotation, but it is the most difficult goal to achieve, but it is the primary cosmetic concern, because the patient always sees the rib hump if you didn't correct it. And we can see it in hump view. This is a preoperative hump view. We can see here the rib hump, which denoting the rotation of the vertebral body, and the correction in the postoperative hump view with the restoration of the rotation of the vertebral body. Direct vertebral rotation is axial plane rotation and correction to the primary correction maneuver, and you need to correct the sagittal profile of the patient and the coronal profile of the patient before attempting to directly rotate the vertebral body. Here, this is a patient preoperatively with the evidence of rotation by the rib hump, and this is the plane X-ray by the evidence of rotation, which can be seen by detecting the Nash-Moe method. There are two types, either segmental, that means we derotate segment by segment, or regional. We connect the region and start to derotate the region by our construct. We rely on applying a screw. Of course, high screw density is required in the apical area, where you then apply the extenders or the smart link to the screws and start to rotate at the end of the correction. My strategy in applying the screws, of course, when you apply uniplanar or axial screws, that's very good. It helps you to derotate the vertebral body. But of course, in the neutral rotation vertebrae, you can use polyaxial screws. In the apical vertebrae, polyaxial reduction screws is recommended. It helps you while applying the rod to the screw to translate the spine. and reduction screws when be possible to be applied. That is a recommendation. Release is important to help you to rotate the spine. The simplest way we do release by doing fascectomies, complete fascectomies, and I recommend to do apical and periapical ponte osteotomies. As we can see here, we did fascectomies and applied the screws, and we did periapical 3 or 4 pontes osteotomies, help us to derotating the spine. While choosing the rod, of course, I choose the biggest diameter, 6 mm rod, if my implants allow to do that. If not, I may use cobalt chrome rod. Some colleagues nowadays speak about cobalt chrome titanium alloy mismatch, and they recommend even cobalt chrome tulip as well. And it is highly recommended that you use differential rod contouring technique to correct the sagittal profile while applying the rod. The concave side rod is usually more kyphotic compared to the convex rod. And at the end, after doing the correction of the coronal and sagittal profile and doing direct vertebral derotation, you distract on the concave side of the rod. This is a small video from one of our cases that we rely on segmental vertebral manipulation after putting the 2 rods in the spine and correcting the coronal plane and the sagittal profile. Of course, the lower instrumented vertebrae is neutral vertebrae and stable vertebrae. You close and tighten the tulip, and then you start to do direct vertebral derotation segment by segment, as we can see here in this video. The lower instrumented vertebrae, the neutral and the stable one, is closed tulip, and this is the proximal segment. Start to rotate it, and we start to push on the convex side and pull from the concave side, and by this mean you can have direct vertebral derotation forces segment by segment, and you repeat this segment. As we can see here, we rotate the spine. This is the convex side here on the left side, and this is the concave side on the right side, and this is the concave side on the left side, as we can see here. The direct vertebral rotation is very beneficial, lead to better coronal curve correction, improve the lower instrumented vertebral tilt, offer shorter fusion levels, and rotational correction can be appreciated by the patient and even can be appreciated by the postoperative X-rays and CT scan, as we will see in the coming few slides. The rotation technique can be done in block, as we will see in this case. For example, you can push on the convex side and pull from the concave side, and you can do it in a region like we can see here in this video. You can see here we connected the screws and the smart link, and we start to derotate the spine, pushing on the convex side and pulling from the concave side. And at the end, concave apical distraction to create kyphosis and to improve the kyphosis, because scoliosis is a hypokyphotic pathology. This is our aim to correct not only the coronal but also the sagittal profile. The last correction technique is vertebral coplanar alignment technique. It relies on putting these tubes in all screws and putting the definitive implantable rod, which is the red one, in these connectors, and start to push it down. And here the spine can be corrected segmentally all through its length, from the upper instrumented vertebrae to the lower instrumented vertebrae, depending on the presence of alignment rod and the reduction rod. And this is present in some systems in our deformity correction techniques. So scoliosis correction is a combination of maneuvers. As we said, it is 7 correction maneuvers, nothing exclusive. No one technique is superior over the others. We actually use all of them in our hands. The end point influenced by many factors: curve reducibility, fixation, and the anchorage points between the spine and the construct, rod bending stiffness, and the bone quality of the patient. For example, if the patient is severely osteoporotic, like in some metabolic patients, I don't recommend to do direct vertebral derotation. In presence of some neural axis abnormalities, we need to be very careful while manipulating the spine in such cases. This is a couple of cases. This is a female patient with adolescent idiopathic scoliosis, Linky 6, thoracolumbar and thoracic curve, thoracolumbar lumbar curve bigger than the thoracic curve. She presented to me with older age, 26 years old, and I did fixation for the 2 structural curves, and I did direct vertebral derotation, and we could achieve good rotation of the patient, which can be appreciated by the location of the tip of the screws inside the pedicle in between the rods, medial convergent screws. When we see the screw tip in the midline, that means post tips medial to the rod. That means you have, or you can appreciate from 0 to 9 degree rotation. When one screw is hidden by the rod, as we can see here, that means you may have from 9 to 12 degree rotation. When the right tip of the screw is lateral to the rod, that means you have more than 13 degree rotation. This is how to explain the degree of rotations by the position of the tip of the screws in the plane X-rays. Of course, if we can see here the ribs in comparison with the preoperative X-rays and comparing the postoperative X-rays, how the ribs are become widened in between in comparison of the concave side, so that we achieve good rotation, and we can see the tip of the screws medial to the rod in the thoracic spine. Here, this is another case. Although we could achieve good coronal correction, but we didn't achieve good derotation technique in the lumbar spine, because we can see more than 13 degree rotation because the tip of the screw is lateral to the rod, as we can see here. Not only in the plane X-ray in posterior anterior view, in the lateral view, when we can see overlap of the rods and superimposed rods in the lateral view, that means you could achieve good derotation as well. So my take-home message that all the 3 axes, either the coronal, the sagittal, and the axial deformity, need to be corrected in scoliosis surgery. Compression, distraction, translation, and cantilever techniques can correct the coronal plane. Rod rotation techniques help to correct the sagittal plane, but direct vertebral rotation technique corrects the axial plane, and it is mandatory for the cosmosis and help you to correct the rib hump, which can be seen and detected by the patient. And the multimodality maneuvers are used in our practice. Thank you so much, Professor Muhammad, for allowing me to share my experience in deformity correction with our friends and colleagues. Thank you so much.
Thank you so much, Professor Khattab, for this very interesting talk. Thank you so much. We have a surprise. After 1.5 hours from now, we will transmit a direct live surgery from India. Professor Malcolm will transmit a direct live surgery from India after 1.5 hours from now. Our next speaker will be Professor Dr. Ahmed Morsi from Ain Shams University, Egypt. Professor Morsi.
Thank you, Professor Muhammad, and many thanks to Banha University for such efforts, and of course for the the Egyptian Association for Orthopedic Surgeon to do such collaborative work with the Banha University. My talk today will be about the percutaneous fixation. I'll share the screen in a second. Can you see it now, sir?
Yeah, it's still working, Dr. Morse.
Okay.
Not yet, but still working. Yes, it's quite obvious now.
Okay.
Full screen, please, sir.
Okay. This talk will be about the percutaneous fixation of spinal fractures and the possible complications. These are the indications for the transpedicular percutaneous fractures of fracture fixation in the dorsolateral spine mainly. The main aim is the fracture stabilization and reduction, displacement to allow fracture healing in perfect alignment. Then later on we can remove or not remove the implants according to the case. Some patients will need fixation without fusion, while others will retain the fixation device if they are fused. Sometimes percutaneous pedicle screw fixation can be used for deformity correction. It's not our scope in this lecture, as well as in some cases of decompression and fusion in lumbar degenerative disc disease and spinal instability. The basic tools or the basic implants are the polyaxial top-loading pedicle screws and rods. These must be top-loading screws, of course, in the percutaneous technique, and the heads should be polyaxial screws. It's very difficult to place a rod in a monoaxial, non-moving screw head. And there are many techniques. One of them is the all pedicle screw, is that the segments needed to be fixed will be thoroughly studded with pedicular screws percutaneously, or if you are going to perform a longer fusion, some pedicles could be skipped for the aim of reduction of time and reduction of radiation exposure to the patient and to the surgeon. These are the typical screws used for percutaneous fixations. They are different from the traditional pedicle screws. Is that they are cannulated screws. They are hollowed in order to be placed over the guide wires, which is primarily or initially placed into the pedicle. Some of these screws are even fenestrated, and in such case, they are called fenestrated or injectable screws with the aim of injection of bone cement through these nozzles in osteoporotic patients to increase the pull-out strength of the screw. Of course, the percutaneous fixation is a strictly image-guided procedure, and proper visualization is very critical and very important. The surgeon must check the operating table, make sure that he is able to take anteroposterior and lateral images in different craniocaudal orientations in order not to be facing a bad situation during the surgery. As I said, the difference is that we don't have all available diameters. The most commonly available are the 5 and the 6 and 7 millimeter diameters, and they should always be top-loading screws and polyaxial screws. The technique is through a percutaneous technique using the C-arm guidance. We are going to localize the level which is fractured, and we are going either to use a monosegmental fixation when there is retained proper intact pedicles and mild to moderate collapse of the superior end plate. We can place 2 screws in the caudal fractured vertebra, but the orientation will not be parallel to the pedicle axis, but rather parallel to the fracture end plate to take the longest distance to allow for better purchase of the screws and to be away from the fractured end plate. The bisegmental fixation, we usually skip the level fractures and fix cranial to it and caudal to it. And sometimes we can place additionally 1 or 2 screws in the intact pedicles in the fractured vertebra. This is especially important in transitional fractures like D12 and L1. The first point is to define the fracture level. This is usually done on the lateral X-ray or C-arm projection. And then we do our stab incision to reach to the entry point on the lateral aspect of the facet joint in the mid point of the transverse process. And to start drilling or start inserting the Jamshidi needles that we use, we have to shift from the lateral view to the anteroposterior view to make sure that the Jamshidi needle is positioned over the outer lateral or the mid-lateral aspect of the ring showing the waist of the pedicle. It's just like this. In this picture, in this illustration, you can see here in the mid point of the transverse process, and the craniocaudal orientation will be depending on the lateral X-ray or the lateral C-arm image. If the vertebra to be instrumented is not fractured, you can go just parallel to the pedicle axis and parallel to the end plate. If it's fractured, you can go in a posterior to anterior-inferior direction to reach the anterior-inferior corner here of the vertebra in order to be away from the fractured end vertebra end plate and to take the longest distance for fixation of the screw within bone. After applying the Jamshidi needle and making sure it's in the proper place, guide wires are applied, and then the Jamshidi needle is removed, and gradually the pedicle screws are advanced over the guide wires until they reach a proper diameters. It's usually enough to take the posterior 3/4 of the vertebra. No need to go further anterior to reach the anterior cortex. If you have osteoporotic bone, you better compensate for this osteoporosis by using fenestrated screws, injecting bone cement within the injectable screws to increase the pull-out strength. The advantages of this technique, the percutaneous technique, is of course minimal muscle injury, reduced blood loss, of course more rapid post-operative recovery, less need for analgesia, less need for staying at hospital, and easier and faster rehabilitation. Of course, the aspect of cosmesis, which concerns the patients, especially female patients, and to some extent nowadays, male patients who go through the internet and hear about percutaneous techniques. But in these circumstances, like the fractured patient, the patient doesn't have much time to think about this, and you should choose the better for the patient and for the fracture and for the better short and long-term outcome. The disadvantages of such technique is, of course, the first thing is radiation exposure. Maybe the patient will take large dose of exposure during the surgery, but if you are a surgeon and you are performing this technique frequently, you may get some hazards due to irradiation. Of course, this technique has a steep learning curve. The complications are not few, especially in the early practicing surgeon. The implants are more costly. Some patients may need removal of implants if we have not performed fusion. So the implants should be removed. Otherwise, there will be breakage of the rods or the screws. And the last thing is that, just as I said, many patients will come to you in some instances like the lytic lysis, for example, or fracture of the pars, wanting to have a minimally invasive technique, not an open surgical conventional technique. As I just said a few slides back, the entry points are important. It differs from dorsal region to lumbar region to S1 vertebra. The craniocaudal inclination you can decide on the lateral X-ray view. The most important point is that you should perform your technique all the time while under clear image guidance. As all of you know, that the orientation of the pedicles will differ from one level to another. Most commonly, usually, but not all the time, the L4 pedicle is usually vertical, and there is an increase 10 degrees cranially and caudally. Of course, if there is a fracture, there will be a difference in this magnitude of angulations. The thing that will be mostly constant is the medial lateral inclination of the pedicle, which will increase gradually from L1 down to L5 and S1, and will then upwards. The pedicles of D12 and D11 are straight ahead, sometimes D10 as well. Then they become more convergent as we start from L5, from dorsal 5 up to D1. Usually the starting point on the anteroposterior X-ray view will be in the superior lateral aspect of the pedicle. This is the pedicle, okay? And this is the superior lateral aspect, especially if this vertebra is fractured. If this vertebra is intact, we are going to start our entry point in the midpoint of the transverse process as usual with the conventional open surgical screws. And this is the difference between the intact and the fractured vertebra. As regards the entry point for the S1, because you need to be more convergent, sometimes if you have a transitional vertebra or you have a high iliac crest, there may be difficulty placing a screw in S1 starting very lateral. So if you fail to get such trajectory, you have to use shorter screws in order not to touch or reach the lumbosacral trunk laterally over the ala of the sacrum. This is the midpoint of transverse process and the inferior aspect of the facet joint. Of course, there is tendency in the percutaneous technique to get a more lateral entry point for the pedicle screws because most surgeons will be afraid to violate the medial wall of the canal of the pedicle, getting into the canal and injuring one of the roots or the spinal cord. As we see here, here is the Jamshidi needle placed, then the guide wires introduced, then the needle removed and the screws are applied over the guide wires. And the fractured vertebra in between, you can decide whether you are going to instrument or not, depending on its location. If it's dorsal-lumbar junction, D12 or L1, it's better to be fixed. If it's L2 or L3, you can just depend on the restoration of the height of the vertebra, and you don't need to fix the pedicles here in this level. As regards the dorsal spine, as we know, the traditional pedicle screw will have two techniques or two directions. The anatomical one, where you have to remove part of the facet joint. This will not be possible in the percutaneous technique. So most commonly, we are going to perform the straight forward or straight ahead technique, which goes parallel through the parallel to the end plate rather than parallel to the pedicle axis. In dorsal spine, also, we have to consider that dorsal 5 has the narrowest pedicles and dorsal 8 has the narrowest canal. So it's better if you perform an in-out-in technique, starting a little bit lateral and avoiding increased convergence or avoiding increased medial inclination. At D12 and D11, there is some kind of difference here. As you can see, here is the pedicle axis, which is divergent. But in most cases, we will need to go for a little bit lateral entry for the screw to be able to go for a more length for the screw, as in this image on the right side. So this is the typical direction of screw placement, although this is the typical direction of the pedicles at D11 and D12. Regarding the S1 placement screw, we may have some difficulty because of the iliac crest in some patients, and you have to go a little bit far, just like this. If you can perform this due to a high iliac crest or any other anomaly, it's better to use a shorter screws, so that if you cannot converge much to this extent, you don't get ending with a screw on the ala of the sacrum and touching the lumbosacral trunk. Also, an important point is that you have to place the C-arm into a proper craniocaudal direction to be able to view the pedicles of the S1 vertebra. In the traditional open surgical screws, we usually use either the bicortical technique or the tricortical technique. The tricortical technique will be aiming at the promontory, and it will have a lower entry point relative to the bicortical technique. It's assumed that this tricortical technique is better advised in osteoporotic patients because it has a better pull-out strength. Now, about the complications. Of course, some of the complications may occur because you're not performing your surgery in an open fashion, like inadequate reduction of a fracture or an end plate. You cannot perform proper distraction to reduce a retropulsed fragment in cases of intact PLL. Sometimes the screws may get the complications like neural injury or vascular injury. Sometimes in osteoporotic patients, screw pull-out may occur, especially if you apply the fixation in junctional area. In patients where you perform fixation for reduction and you don't perform fusion, retaining the screws for a long time may result in rod or screw breakage. These are illustrations for some of the possible complications. Medial violation of the pedicle wall here may injure the coda equina or the spinal column higher up in the dorsal spine. A little bit lower positioning of the screw may injure a nerve root or cause root irritation. Too enthusiastic advancement of the Jamshidi needle or the wire or the screw may injure the vena cava, which is more liable to be injured, of course, on the right side. This is an example of a percutaneously applied screw, which is violating the superior-most area of the intervertebral foramen, which is where the nerve root usually is present. Another example of medial wall violation of the pedicle in the lower dorsal spine. Sometimes this may end up with no complications or no symptoms at all. And in such cases, you may leave the patient in peace and not try to revise the screw. And sometimes the screw is far medial and intruding into the canal like this one. And this, of course, is highly suggesting that there is a cord or coda equina injury. This is, of course, in the dorsal spine, so it's here, it's a cord here. Also in the sacral, lumbosacral area, regarding the L5 pedicle screw or the S1 pedicle screw, the presence of anomalies in the lumbosacral junction or anomalies in the iliac crest, the posterior iliac crest could lead to such complications such as violation of the medial pedicle wall and intruding screws into the canal. Then we come to another modification which may reduce this complication, like the pull-out, the screw pull-out complication, especially in osteoporotic patients where we apply the fenestrated screws, where these screws, after being applied, are injected with methyl methacrylate cement. And as we see here in a CT scan, performed intraoperatively, in severely osteoporotic patients, the bone cement may fill the whole body. And of course, too enthusiastic injection of cement may end up, if the patient is having a fracture, trickling backward into the spinal canal, causing compression on the spinal cord or the coda equina. Another modification for the percutaneous technique is augmentation of the vertebral body, fractured vertebral body, after reduction of the fracture using the screws and the position, of course, and the manipulation in the operating table. You can inject vertebroplasty, cement augmentation, methyl methacrylate cement into the vertebral body, especially in osteoporotic patients, to help add further support and remove much of the load on the percutaneously applied screws. I mentioned this example because the title of the lecture is Fractures of the Spine. So let's consider that this dysplastic defect or this lysis is considered a fracture. Some may argue about that this is maybe a congenital pre-existing finding or some degenerative condition, but it's actually described as a fracture or lysis in the past. So some patients can be candidates for percutaneous fixation, reduction, and of course, this technique will not just be done in using the 4 holes for the 4 screws, but on one side, the patient, the patient is more symptomatic, we can open a wider incision between the two screws incision to perform TLIF, discectomy, and insert an interbody fusion cage. And this is the typical scars present for a patient with 4 screws applied percutaneously. Another thing regarding the fractures, percutaneous fracture stabilization, let's say, not fixation, is the fixation or treatment of osteoporotic vertebral fracture using just cement augmentation. Of course, all of you know about vertebroplasty and kyphoplasty, where the same Jamshidi needle is introduced transpedicularly under image guidance, and then bone cement is injected to solidify within the vertebral body. Care should be taken that we don't inject much cement, because some cement may trickle backwards into the spinal canal, even if the patient has an intact posterior vertebral border, especially in patients with pathological fractures or with severe osteoporosis. the modification of vertebroplasty is kyphoplasty, where there is theoretical reduction of the depressed end plate by inflating a balloon temp by a radio contrast material. Then this is deflated and removed, and the semen is injected into the vertebral body. Of course, the reduction of the end plate, especially in the vertebroplasty, is usually performed by proper positioning of the patient in some kind of hyperextension using pillows, or by breaking the table to put him in extension, not of course by the injection of the semen. Finally, the types of
Dr. Morsi? Professor Morsi? Dr. Ahmed, you are with us? Dr. Morsi حصل عنده بس disconnection, and he will be just in 2 minutes. He will be with us. Professor Muhammad Abdel Al, how are you?
He is a mute. Muhammad, unmute yourself.
سلامته بس يا فندم.
الحمد لله على السلامة يا محمد.
سلامة يا دكتور محمد. ألف حمد لله على سلامة حضرتك.
شكرا لسؤال حضرتك عليا.
ربنا يديك الصحة يا فندم.
دكتور احمد هنعرف نرجع له عشان عندنا شويه.
دكتور احمد
نرجع دكتور احمد نرجع خلاص.
دكتور محمد, I'm sorry for this disconnection. Okay. Is it shown now, the screen, my screen?
Yes.
Okay.
Yes, sir.
So,
حضرتك كنت واقف عند الكيفوبلاستي يا فندم.
اجيبها حالا بيها. Yes. So the kyphoplasty is just a modification of vertebroplasty to avoid cement leakage into the canal, where there is theoretical reduction of depressed end plates by introducing the Jamshid needle, then the balloon temp inside. It is then filled with radio contrast material, assumed to elevate the end plate to perform reduction of the fracture. Then this contrast material is withdrawn and the balloon deflated and withdrawn. Then cement is injected to solidify, maintaining the elevated or raised end plate. Of course, the reduction in vertebroplasty, the reduction of the fracture of the improvement of the vertebral height after vertebroplasty is usually attained by proper positioning of the patient on the operating table, by putting extra pillows under his hips and chest in order to perform or to maintain some kind of extension. Then cement is injected in such extended position with slight regain in the height. Then it solidifies and the patient can go out. And of course, this whether the vertebroplasty or the kyphoplasty can be performed under local anesthesia and conscious sedation. Lastly, the indications of fractures which can be managed by percutaneous fixation. As Dr. Waniz mentioned, some of the the types of the fracture or all the kinds of the fractures of the spine, especially the burst fracture in the dorsolumbar spine. Actually, fractures in the cervical spine has not been treated by the percutaneous technique except very rarely and not supported by many also because of the danger and because many of these usually have, if surgically indicated, they usually have neural deficit associated. Chance fracture or the flexion distraction injuries, which are usually without neural deficit and without much displacement, to the extent that lateral X-rays can sometimes cannot show the fracture. So this patient should be managed operatively, and they can simply be fixed by percutaneous fixation. Lytic lysis, as I just mentioned, with adding interbody fusion in the form of mini TLIF, removing the facet joint and the intervertebral disc and placing a graft-filled cage. Stable burst and compression fractures can be fixed, although it's not a typical indication, but sometimes they can be fixed if the patient is having pain, prolonged pain cannot be controlled by medications or bracing. And of course, it can be augmented by vertebral augmentation, cement augmentation, or without fixation and just vertebral cement injection. Of course, it's contraindicated in any patient with a neural deficit and in fractures diagnosed or classified as fracture dislocation. As a summary, the percutaneous technique for fracture management has many advantages. It also has many potentially serious complications, but the frequency of complications is much reduced with a prolonged learning curve. It's better for surgeons who start practicing percutaneous fixation to perform it under more senior supervisions, and there's always, every now and then, there's a modification and additions to facilitate patient rehabilitation, facilitate patient recovery, reduce bleeding, reduce hospital stay time, and so on. And thanks a lot for you, Dr. Mohammed, and for the audience and the panel of this nice meeting.
Thank you so much, Professor Ahmed Morsi and Shams University, Egypt, for this very comprehensive and illustrative talk. Thank you so much, sir.
Thank you, sir.
If we have any questions to Professor Morsi?
Yes, thank you, Professor Ahmed. It's very nice presentation.
Thank you, sir. Thank you, Dr. Mohammed.
Dr. Baha Qurna. I make a small modification and make it meso. I go just over the pedicle and make a small opening and dissect to the either side. Then by identification of the pedicle entrance, I go directly in both sides, and then percutaneously I pass the rod in both sides, and I can fix it, and I call it is meso technique, and I use it, and it is minimally invasive. In the meantime, you don't need to use a lot of radiation. This is a technique I adopted it, and we publish it.
I think Dr. Ahmed is lost his connection, I think.
Okay.
Okay, now we will move to the next speaker, Professor Baha Qurna, Al-Azhar University, Egypt. Professor Baha.
Thank you.
الدكتور احمد مش راجع تاني؟
I think we after Professor Baha, Dr. Mohammed.
التصنيف ده احنا الدكتور ده طبعا عارف ان احنا عملناه من حوالي 4 سنين وماشيين دي بيبر، فكان في عندنا شويه اوبستكلز بتقابلنا، كان نفسي اعرف راي الدكتور احمد فيها وازاي بيتغلب عليها.
I think he will be with us shortly. Professor Baha?
Yes, thank you, Dr. Mohammed Ashab, for this invitation. Also, I congratulate you as a dean of the university. Also, we appreciating your effort and cooperation between you and McMaster's University in Canada, which you are selected as one of the member, and the cooperation between Banha and Banha University Faculty of Medicine, and also the McMasters, and put the Egypt name in their 43 country as for the cooperation between McMasters and this university. Thank you, Mr. Mohammed Ashab, for your effort, and thank you also for all Banha staff. My talk today about surgical in geriatric spine, how to be safe. if we're looking for the epidemiology, evidence is that older people experience more disability, low back pain than younger people. As the old population grow, it is important to persuade method for delaying the natural history of developing of low back pain in geriatric. The geriatric is rapidly expanding subset of population. Now we have a lot of population and the people grow up. If looking for 65 age more increasing from 12% to 20% of our population. And the people who are above 85 will grow by 50% in the future. Utilizing more medical resources for these people, the geriatric people, they use 90% of healthcare resources in the last 10 years of the life, spending more time in the ER and more likely to receive ancillary tests and the high admission rate to the hospital and high use of ambulance. So what is the effect of the aging effect on the spine? It has two types of effect, either in biomechanical change and the morphological change. From morphological change, looking to the bone, there will be changing in the bone, the vertebral body, and the facet joint. Also the soft tissue, the intervertebral disc, the end plate, and the muscle and the ligament. From the biomechanical point of view, there is a creeping characters of the intervertebral disc, also the kinematic function of the spinal unit, and the compressive strength of the vertebral body will decrease stress, and the interdiscal pressure across the intervertebral disc also affected, and the loading share will decrease. So with any surgical, there is a risk of complication, but in geriatric, the risk is more. So be aware about that we are dealing with elderly people. This is the type of spinal surgery we can do for the geriatric, like intradural injection, fusion, instrumentation, deformity, low back pain, lysis, tumors, stenotic disc, decompression. All this is a kind of surgery we can perform to the geriatric people. So the complication in geriatric people can be divided into two groups, and this group can be subdivided. The first group is a specific patient problem, which we are dealing with the geriatric patient. Also spinal surgical problem, the general complication and the local complication. This Perwetti et al. Making a complication based on the different predisposing factor, and they put a lot of complication and the number of the people who's facing bariatric. He said that a systemic preoperative evaluation should always be performed in order to stratify the risk and to guide decision making for obtaining the best possible clinical result at low risk, even for elderly patients. So this complication be for surgery. It can be general, like mortality, anesthesia, DVT, bleeding problem, blood clot, chest and urinary infection, persistent pain, and positioning. Local, like neural agent, dural, bleeding infection, implant and diffusion complication, like pseudoarthrosis, instrumentation failure, and transitional syndrome, which are affecting the intervertebral disc. How to avoid this problem? To consider the aim of the surgery is very important. You aim from the surgery to this geriatric patient. Deformity analysis before you go for surgery. Sagittal balance for these old people. Osteoporotic of the vertebra and the presence of comorbidity. The geriatric orthopedic condition is not just about the orthopedic treatment. We are facing with a plethora of comorbidity conditions that make our job difficult. Think about diabetes, obesity, hypertension, osteoporosis, cancers, vascular problem, and dementia. So when you are thinking about do surgery, think about these three questions. What are the benefits? Are there is a risk? What are the back surgery pros and the cons? What are the benefits for this surgery? Often the result is more than just a dropping in the pain. You maybe find that this patient has a better movement, has a physical fit, more mood improvement, less pain medication, back to the work, and more productive at work. This is a benefit of surgery. But what about the risk? Most of the people who get back surgery have no complication, but there is some complication can be occur, like reaction to anesthesia, bleeding, infection, blood clot, heart attack, stroke, herniating disc, nerve damage, and other neural complications. This is Nancy Epstein published this spinal surgery in geriatric patients, sometimes unnecessary, too much or too little. This is a surgery 2011. Increasing for spinal operation in geriatric patients with multiple comorbidity are sometimes unnecessary, offer too much surgery instrumentation or too little surgery miss. Claudi in 2008, a better understanding of the risk and the prognosis associated with this type of surgery will enable more informative decision making by the patient and the physician. This is Ahmed Salah and other mentioned about the complication and readmission after lumbar spinal surgery in elderly patient, analysis of 2,320 patients in Spinal Journal 2017. In conclusion, elderly patients undergo lumbar spinal surgery have a high complication readmission rate. Risk factor for complication including longer operative time and more extensive procedure involving instrumentation and diffusion. High readmission rate are associated with low baseline patient function status and low patient PMR. So remember, for the geriatric patient, remember that the senior citizens are valuable. We are more valuable than any of the younger generation. We have silver in our hair, we have gold in our teeth, and we have stone in our kidney, and we have lead in our feet, and we are loaded with natural gas. So the item of success for any surgery for geriatric, the surgeon, the bone, and the implant. So always think before surgery, think before surgical in geriatric patient. So the preoperative planning, also the intraoperative and post-operative and rehabilitation, the stages for any geriatric patient. Period to any operation, the time which is a surgeon devoted to a careful preoperative planning is a critical, important, and often determine the success or failure of the procedure. So put it in your mind. So surgery how to be safe by preoperative planning and expectation of neurological complication. Started by complete patient history. This is we needed to make a decision looking for this patient geriatric has a problem, aging spine, aging hip, aging liver, aging kidney, aging GIT, aging CNS, and comorbidity. The effect also the drug are no longer a safe option. Stenosis, strenuous exercise are ruled out. Management comorbidity is a challenge. So diagnosis of the problem is so stop and think before doing the surgery. So all geriatric patients are not created equally. So traditional diagnostic approach, a history of the present illness, medical and surgical history, physical examination, investigation, and diagnosis, and maximize your plan. Think about CNS, think about cardiovascular, respiratory, GIT, urinary tract, and the immune system. Surgery how to be safe by preoperative planning and expectation of neurological complication. Started by complete patient history, meticulous examination of motor, sensory, and reflex function, as well as gait assessment is critical. Elderly patients, they have multiple organ dysfunctions. So think about physical, mental, financial, and emotional and social. This is a geriatric patient challenge. Aging-related cardiovascular changing in the patient with geriatric. They have a reduced autonomic responsiveness, SNS activity increase, parasympathetic decrease, parareceptors reflex decrease, B adrenoreceptors responsibility decrease. Also decrease in the maximum heart rate. And frank starting mechanism, major mechanism of the maintaining stroke volume. And this is diagram that you have to Yes, Mr. Tanner, that was very loud, Mr. Tanner, but I said I wanted to hear your heart. What about the aging-related cardiovascular changes? There is an increase in vascular stiffness, increase with systolic blood pressure, widening of the pulse pressure, the left ventricular wall thicken, decrease for compliance, impairment of diastolic function. Also, the great dependency on the atrial function for ventricular failing, contributing up to 30% of SV. Aging for the respiratory, decrease in vital capacity, increase in the residual volume, decrease in strength and mobility of the muscle, lung elasticity recoil decrease, also chest wall compliance decrease, and the spinal collapse anterior wedging occur in geriatric patients. Increase with closed volume capacity and increase ventricular and over Q abnormality, decrease with gastric exchange. Aging related to respiratory change, there is hypoxia and hypercapnia reflex control decrease, and poor upper airway tone, snoring almost universal, poor cough, decrease for 7-fold, reduction in sensitivity of cough reflex, increase the risk of aspiration, that can be a silent aspiration, chest wall rigidity, it is more dependent on the diaphragm and not on the intercostal muscle. The lung problem, which is very important when you put the position of the patient in the prone position, is very important. Post-operative medication, it all can be affected and delayed immobilization. Age-related to neurological change, decrease in brain cell mass, which is about 10 to 30% by the age of 80. Loss of the central cholinergic and dopaminergic cells, 70% to 80% loss of dopaminergic function required before symptoms seen in Parkinson's disease. Crystallization, intelligence, better preservation of liquid intelligence. Poor reflex control. What about neurological changes? There is a blindness, cataract, and glaucoma, which are affecting the patient mobility. Problem with visual analog scales also can be affected by geriatric. Deafness, problem with comprehension, and may be denied by the patient. Cognitive impairment, which is dementia, present in 20% over 80 years. Life expectancy, 50% in 5 years. What about the hepatic related, which is very important for drug mobilization, drug metabolism? Decrease the liver mass and the blood flow, 1% loss per year after 30 years. Minor change in cytochromes, P450 activity, variable effect on phase 1 reaction and phase 2 not affected. Drugs which are flow limited, affecting the greater than capacity limited. And reduce the albumin, altered the drug in binding. What about the renal? Also marked decline in RBF and glomerular filtration rate, 1% loss of function after 30 years. Plasma creatinine not good guided for renal function because of reduced muscle mass. Response to the sodium concentration impaired and less able to excrete the sodium load. Reduce the ability to dilated and concentrated urine. Decrease the thirst perception, fear of incontinence, locomotor problem, inability to get to the fluid. What about the orthopedic changes? There is also arthritis and osteoporosis, and immobility, increased venous stagnation, and the limited ability to exercise. Poor stability and balance, increased risk of accident, especially in unfamiliar surrounding. Also, there is a ligament laxity or stiffness, the cervical vertebra slipping, and this is degenerative arthritis. And also arthritis problem should be aware when you're dealing with a spinal patient. Reduce the joint movement, airway management, intravenous access, the spinal and epidural may be difficult. Positioning of this patient with a stiff spine, concurrent analgesic therapy can be affected by the liver and the kidney. So the first level classification is serious pathology. There will be sleep disturbance, bowel and bladder dysfunction. You have to ask it about unexplained weight loss, recent episode of fever related to the low back pain and the trauma. This is very important to ask directly to the patient. How to be safe if a medical condition questionable, so go for non-surgical management. Physical therapy only, go for phase 1, phase 2, phase 3, and consultation for any inflammatory process and can be treated medically and also psychologically. And you can refer patient for medical, psychological, and very rare to surgery. The outcome assessment and placement, inherited risk of operation, the size of the stress response on the patient. Is it appropriate surgery for this patient? Matching of experience of the surgeon and assist to the physical status of the elderly patient. Very important to be done by a senior surgeon. Plan appropriate anesthesia technique and surgical technique. Appropriate post-operative care for the ward or ICU. And complication in summary avoided by pre-operative planning and careful surgical. Careful surgical by anticipating the surgery. So the pre-operative planning sometimes is very important because if you don't, you have some people do some excuse. I don't need to do a pre-operative planning. This is wrong. I accepted that maybe I needed to plan difficult cases, but I don't need to do it with an easily. Don't pre-operative plan take too much time. Please, before any geriatric patient, do a pre-operative planning. By pre-operative careful surgery, by appropriate case, deal with by appropriate case. Day or in inpatient surgery, minimize the disorientation and the stress for the patient. Social support must be in place. Outpatient surgery reduce post-operative cognitive dysfunction. The pre-operative management, the pre-medication, avoided if possible, avoided lifespan and avoid the bethidine. Give all regular medication, very important for the patient, for geriatric patient, including nicotine patches and alcoholic. Pre-operative fluid and bowel preparation is very important for elderly. Maintain dignity and the nature to remain in place. Give all regular medication, antihypertensive, steroid, aspirin, non-steroidal, avoid analgesia and immunosuppressive drugs. Very important, the position of the patient. It's supine, lateral, prone, and the beach chair in the operation. Why it is positioning important? Enable the intravenous fluid and the catheter to remain in patent. Enable monitoring to function properly. Facilitates the surgeon approach and patient safety. The prone position, very important, looking for the prone position. Always we do for spinal surgery. Face down, head placing, head straight forward, ET tubes placement and patency, check bilateral eye and ear for pressure point. Head turned, check for, depending on the eye and ear, ETT placement, be aware of potential vascular occlusion. Positioning, very important, abdominal decompression is very important in elderly, natural pressure or traction, ulnar or brachial plexus injuries to be avoided. Eye risk of central scotoma and hypotension can occur on turning. Tubes, IV, CVP, dislodging on turning, and neurological injury on turning can be occur if there is instability. Positioning is very important to avoid the pressure point during prone position. The arm placement is very important because don't forget the arthritic and the stiff joint, turning similar to supine, abducted, the check the neck rotation and the arm extension to avoid the brachial plexus injury, and the elbow are bad. Chest rules and iliac support is very important to avoid pressure on this bony prominence. This is an example of some patient with the prone or chest or sitting position. The proper position for prevention of pressure sore and the muscle contractions. Intraoperative complication can be occur and has been avoided. Direct and indirect injury related to surgical technique, a relative inexperience of the surgeon. So we advise it to have this surgery by the senior. Failure to follow the meticulous surgical technique and history of period surgery procedure on the patient. If this patient has a surgery before, you have to be meticulous to avoid any complication. Post-operative cognitive deficiencies. This after the patient has been recovered. Sometimes patient presenting or suffering from the post-operative cognitive deficiency. This is a complex clinical picture that including disorientation. Patient after surgery can be disoriented or suffering from delirium or dementia or personal changes. And this is the incidence of post-operative cognitive deficiency, which is published in 1998 for the study of 1,100 patients over 60 years. They found that 25% deficit at 1 week, about 10% deficit at 3 months, and 10% at 2 years. So the post-operative cognitive deficiency can be occurred. The causes of post-operative cognitive deficiency, not hypoxia or hypotension, not general anesthesia, but maybe due to stress response to the surgery, prolonged hypocorticolemia, central catecholamine changes, decline in the central cholinergic function, genetic predisposing can be occur as a in cognitive study. Infection can be occur in elderly. Infection occur in less than 1% of spinal surgeon. It can be either superficial or deep. The risk factor for this is obesity, diabetes, immunodeficiency, malignancy, AIDS, or internal fixation. Wound infection factor, the nature of the wound, looking for the age, the presence of medical problem, duration of the operation. And local factors can be due to adequate tissue blood supply and elderly devitalization of the tissues or presence of a deep space leading to hematoma and seroma. Foreign body presentation, systemic factor like elderly, obesity, systemic illness, and meticulous medication taken like steroid. Post-operative is a concomitant which leading to infection. The most common is a pulmonary infection, can leading to ataraxis, endotracheal intubation, aspiration, urinary tract infection can occur in elderly and wound infection. Geriatric rehabilitation is very important post-operative, specifically for the joint by elective replacement and fracture, stroke, and general medication problem. So assistive device is very important, and you have to know how to use it and ask the physiotherapist to continue with these patients because mobility is very important after spinal surgery. You can use large basic crutches, two-wheel walkers, four-arm support attached to the two-wheel walkers and wheelchair. Geriatric rehabilitation is very important. General aspect identifies the correct diagnosis, assessment for comorbidity involving the patient and his family, and the team approach to the care and preventing complication, ABC. This is a geriatric rehabilitation program, and the people who is looking for it. Exercise and using assistive devices, which help aid mobility aid, orthotic adaptive method and equipment. This very important to know that the device and the support can relieve about 15 to 20% of the body weight. Crutches leave about 100 of the body weight. Walker give about 50% of the body weight. This is an example of assistive device can be used by geriatric patient. Geriatric preventing complication ABC by physiotherapy, aspiration, anorexia, and inactivity, which source constipation, contraction, cognitive, DVT, and infection, urinary tract pneumonia, and pain and incontinence. So at the end, the fatality, inappropriate procedure with no benefit in longevity, heroic surgery therapy, senior decision to operate, palliative surgery must be provided for symptomatic relief only. human life. This is the last slide, and you have to know this is your life. You're starting by somebody pushing, and then trying to walk, then by bicycling, driving a car, go by somebody, then by ambulance, and by wheelchair, and somebody helping you. This is the wheel of the life. And thank you, Professor Dr. Ashraf, and sorry for long lectures. Thank you.
Thank you so much, Professor Qarana, for these very interesting talks, sir. Thank you so much, sir. دكتور احمد مرسي معانا عشان الكويستشنز يا فندم.
اتفضل يا فندم مع حضرتك.
محمد حضرتك كان ليك كويستشنز دكتور احمد بيه.
دكتور احمد كنت
دكتور محمد معلش انا اسف حصل ديسكونكشن النت بس معلش.
يا فندم العفو يا فندم.
دكتور احمد كنت عايز اعرف منك
معلش بس انا مش سامع الصوت يا دكتور محمد.
بقول لحضرتك كنت عايز استفسر منك ازاي بتقدر تعمل ديكورتيكيشن لو انت محتاجه بالتكنيك ده.
معلش ممكن حضرتك تعلي صوت بس؟
ازاي how to do a decortication if you use your technique. decortication.
بالنسبه لو انا هعمل فيوجن الديكورتيكيشن بيبقى عن طريق ان نفس الاوبننج اللي بنخش منه في السكرو بيبقى جاست ادجيسنت للفاسد جوينت. فقبل حضرتك ما بنبدا نخش بالسكرو بتاعنا بعد ما نحط الجايد واير ممكن نعمل ايضا ان انا بستنى لغايه لما احط الجايد واير وبي يوزنج كريت سمول كريت ابدا اكحت اللاترال سايد والفاسد جوينت على قد ما اقدر. طبعا ما بقدرش اعمل زي في الاوبن تكنيكس لكن بنحاول نكحت الجوينت. بعض الاحيان ممكن بيفور انتروديوسنج الجمشيدي نيدل في البدايه بنعمل الستاب ووند بتاعنا وبنعمل بدايليتور او موسكيتو نعمل وايدنج يعني نعمل سيبريشن للانترماسكولار بلين ولغايه لما نوصل على الفاسد جوينت قبل ما اعمل انترودكشن للجمشيد النيدل او للجايد واير ونبدا نكحت الفاسد جوينت. طبعا في الاول بكونفيرم الليفل بتاعي على الايمج انتنسيفاير وبعدين ابدا اكحت الفاسد جوينت. لو هعمل فيوجن في حاله ديجنراتيف يبقى الافضل ان انا اعمل انتر بادي فيوجن بالذات لو فيها لايسيسز او فيها ترانسليشن ومحتاج اعمل ريدكشن وهيبقى فيه لود على السكروز.
دكتور احمد always we think about the people who is an fracture is younger people and we are trying to preserve the facet joint and we try to avoid the violation of the facet because after removal of the implant we have if we preserve the facet this will be a healthy facet for futures. So if you are dealing with the fracture spine in young, I think it is better to avoid any violation to the facet joint.
بالظبط يا دكتور اهي واحنا دايما اغلب البيشنتس اللي بيعملوا بيركوتينيوس اغلبهم the majority will not need fusion. So we are planning ان احنا at the time of fusion documented بالسي تي سكان بنعمل ريموفال اوف ذا امبلانت عشان كده بنحاول نبعد عن اي فايوليشن للفاسد جوينت. لكن انا هفترض ان انا في عندي فراجمنت مثلا فيها انستيبل بيرست وان انا مضطر اعمل فيوجن دي الحاله اللي كنت برد فيها على دكتور محمد عبد العال لو احتجت اعمل فيوجن. لكن most of the cases of fracture spine حتى الميدل ايج منهم بن go for instrumentation for the aim of reduction and stabilization of the fracture until healing or union then removal without performing fusion.
Thank you.
حضرتك ذكرت في الكونترا انديكيشنز انه وجود النيورال ديفيسيت.
تمام.
احيانا النيورال ديفيسيت بيكون سببه الكومبريشن اللي حصل من ريترو بالسد فراجمنت ودي لما بنعمل ديستراكشن الفراجمنت دي في معظم الاحيان.
معلش يا دكتور محمد بس انا مش سامع الصوت.
انا مش حريف قوي في الكمبيوتر مش عارف. الصوت مش واصل لحضرتك كده؟
قرب جنب الميكروفون قرب جنب الكمبيوتر يا محمد.
انا
عشان السماعات بتاعتك
ضعيف بس يا دكتور محمد.
نعم.
في عندك سماعه تحت اضغط عليها وزودها ل 100 سبيكر تحت شعار سماعه اضغط عليها
الصوت كده واضح يا دكتور احمد؟
ايوه اتفضل يا بيه.
كمل يا محمد.
اتفضل يا دكتور محمد، اتفضل يا فندم.
دكتور احمد
اتفضل اتكلم يا محمد. محمد عبد العال اتكلم.
اتفضل حضرتك عشان الدكتور عبد الفتاح معانا عشان المحاضره بتاعته. اتفضل يا دكتور محمد. اتفضل يا دكتور محمد. Okay, we will have to move to the presentation of Professor Fatah Saud, the Vice President of the Ain Shams University. Professor Fatah, you are with us, sir?
Yes, sir, I'm here.
تفضل يا فندم.
منور دكتور محمد. دكتور فتاح ما شاء الله.
السلام عليكم.
اتفضل يا فندم. سلام الله وبركاته يا فندم.
اتمنى تكونوا سامعيني كويس واسف ان انا معالي العميد، انا اسف ان انا لخبطت لحضرتك المواعيد
لا يا فندم العفو، المواعيد متظبطه على معاليك. العفو يا استاذ.
العفو يا فندم، العفو. وطبعا انا شايف الكثير من الاخوه يعني الاعزاء جدا 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 جدا، عايز اذكرهم بالاسم لكن طبعا عارف وقت البروجرام ضيق.
المفاجاه بعد معاليك يا فندم في لايف سيرجري هتتنقل من الهند لايف.
طب تمام، هيبتدوا امتى ان شاء الله يا ريس؟
بعد معاليك يا استاذنا ان شاء الله.
طيب يا فندم، انا عموما جاهز ان شاء الله. طبعا I'm not sure if the audience are all Arabic speaking or not, so I will presume that or assume that some of them are non-Arabic speakers, so I will give all my presentation in English. I was asked today to talk about the role of open surgery in degenerative scoliosis, and describing this issue would take us to some description of the pathology and the classification of management of degenerative process and degenerative scoliosis. This is the Saffron Palace, which is the seat of higher administration of Ain Shams University. I'm honored to have my office there, and this is Ain Shams University Specialized Hospital. For those who don't know me, I'm Abdel Fattah Saud. I'm the past president of World Spinal Column Society, and I have the honor of being the professor of orthopedic and spine surgery in Ain Shams University. I always, actually, we were giving this same talk in a live surgery course a few days ago that belongs to the World Spinal Column Society that we called Pearls from the OR, and that's why we were doing this in a very practical way. I will show you what did we discuss a few days ago about pearls in the OR regarding this scenario. So I will start this by semi case or half of a case. This is usually what we see in the images of degenerative scoliosis. Degenerated spine, double curve, translation of some of the vertebrae, loss of disc space of some others, some dysfunction of the motion segments. So this is part of the case. The full case I'm going to describe after I talk a little bit about the pathology of degeneration in general in spine. And it's all about these 4 points. Where is the pathology? What are the symptoms and clinical scenario? Solutions, and then how to execute those solutions. And when I talk about execution of the solutions, I'm today going to describe a little bit some pearls from the OR about the open surgery for degenerative scoliosis, because talking about other many invasive options may need another talk. So this is what happens for the motion segment when it gets gradually dysfunctional because of disc degeneration. The first stage is just stage of dysfunction, where there is disc degeneration, some minor tears of the annulus and disc dysfunction, synovitis of the facet joints, and beginning of the stretching of this facet joint and ligaments. But the subluxation that ensures is minor. and would not cause real instability of those motion segments. So we can call it a stage of dysfunctional motion segment, where the function of motion segment is not perfect. And then the body tries to heal that by forming osteophytes, mostly around the facet joints, and some of them are anterior. And the where are the osteophytes is very important in management, as I'm going to describe in a few minutes. This takes us to the next stage, when degeneration is more, and the fissures that shows in the annulus become wider and unhealable, and the facet joint changes become more persistent with more laxity of the capsule, and then this functional motion segment is now hypermobile. The body tries to inhibit this by forming osteophytes, as I said, around the facet joints mostly, some of them anterior in the interbody space. And then we come to the stage of stabilization, where the formed osteophytes gets this hypermobile segment into stability. But the problem, it brings it into stability or settling of the motion segments with some narrowing of all the pathways of all neural elements that come out of the spine. And that causes the degenerative lumbar stenosis, which is usually central, but it could be lateral stenosis, either in the form of lateral recess stenosis or far lateral syndrome. What causes deformity is that this degeneration would not happen symmetrical on both sides. Osteophytes, degenerated facets, and degenerated disc spaces are frequently asymmetrical, with scoliosis development leading to foraminal stenosis, especially at the site of concavity. We need to know that each lateral bending of any segment, especially of the lumbar spine, or mostly of the lumbar spine, is coupled with rotation. So bending happens with some rotation. So when there is lateral bending deformity, there is rotatory deformity as well. And the more we get deformity, deformity begets deformity, with larger lever arms working on that deformed spine causes more deformity. The problem gets worse because of the presence of osteoporosis in a lot of those patients. So the shape of the vertebra deforms, and it becomes wedge-shaped in the anteroposterior view. And this causes more persistent scoliosis for that patient. The more the spine gets deformed, we can get also lateral displacement of the vertebrae, which we call olesthesis. We need to know that osteophytes develop more in the concavity of any curvature, and this should be taken in consideration if the curve correction if we try to reduce this curve while we are performing surgery. We need to free all the nerve roots in the concavity before doing any distraction or compression that I'm going to show you now. Otherwise, you are jeopardizing those nerves. Before talking about surgery and how to think about it, we need to know the goals of our surgery. It's to normalize and balance the sagittal and coronal spinal contours, prevent further progression, fuse the least number of segments, protect and or decompress the spinal cord and nerve roots, obtain solid biological fusion, improve mechanical pain, and avoid perioperative complications. These are the 6 levels of operative treatment of degenerative scoliosis that I still use. There are more recent methods of thinking of surgery in those patients, but I use this Linky Selva that talks about 6 levels of treatment that I'm going to discuss with you on these case scenarios just now. So this is to complete the images that you've seen, and I said this is half of a case, but it's all about the clinical scenario. So this is a 78 years old female, long history of back pain, history of L345 radiculopathy. Recently, she got gait changes, more falls, right-sided partial drop foot and toes. Up till this point, and with the images that you have seen, you might think of a large surgery and doing everything needed for this patient, but take these notes. She's cardiac, previous coronary stenting and on Plavix. She's moderately impairing her kidneys. Serum creat is 2.4 and creat clearance is 25 milliliter per minute. Fatty liver. And on consulting the anesthesia, they said, you can operate on it, on this patient, but without doing anything to cause operative hypotension or blood loss and avoid long surgery. So again, where is the pathology? What are the symptoms and clinical scenarios? Very important. And then put reasonable solution for this patient and then see how to execute it. So specify the routes affected. EMG may help, and maybe some injections. Compression only or instability. So if there is compression here of L3, 4, 5 routes, for example, and it's mainly on the side of concavity, this is very reasonable, and it's confirmed by EMG. Would this be just compression or instability of those segments? And if you decompress those segments properly, and that's why you need a CT, would you cause iatrogenic instability or not? Dynamics are very important. MRI, both static and dynamic MRI. I especially note this in my department now because we finally have a dynamic MRI done in Ain Shams Specialized Hospital, which helps a lot. And also the sagittal balance. We need full standing X-rays to see if the pelvis is really horizontal or not, and if the sagittal alignment is really acceptable or not. Gait analysis is important, and this important question that I've just mentioned, if you're going to plan only for decompression, which we call stage 1 treatment of Linky-Selva, would you fully decompress this part or these segments without destabilizing the spine? And if you are going to destabilize the spine, how many segments you are going to destabilize? This is very important. So with this scenario, there is only radicular compression, no instability, balanced or compensated spine. Most probably decompression will not cause significant instability, and the patient is in stage of stabilization, and most probably there are anterior osteophytes that would make this segment stable. And there is a condition that no more than 2 millimeters of subluxation or olisthesis of the vertebral segment. And also there is something very important if you're aiming to decompression alone, which can be done minimally invasive or open. The problem of back pain should not be the major issue, because decompression would help radicular symptoms, but it might increase back pain if it is not associated with any kind of stabilization. The curve should be less than 30 degrees. And there should be no significant increase in the thoracic kyphosis. Otherwise, you need to correct that as well. And this, you can see that the conditions for decompression only are not easy, especially in our country where the patient really comes late. This is an important demonstration that I'm going to show you. On this demo, you need to know that the osteophytes usually forms around the foramine, especially in the facet area, and decompression would necessitate that we work along all these areas to cause decompression, especially if you are going to do fixation. This is an important demo that shows you that you need to decompress both exiting and traversing nerve roots, because around each facet, as you are going to see here in this demo, and you are going most probably to work on this concavity, you can see that around the facets, there is a proximal nerve root affected and the distal nerve root affected, exiting and traversing nerve roots. Both of them, if you are aiming to really decompress this segment, needs to be decompressed. So this is the scenario when you're going to cause decompression only or level 1 of treatment. This is the second scenario. Pure radiculopathy, yes, but there are unstable segments that that needs decompression, or your decompression planned on the CT is going to decompress these segments. But back pain is not a major issue, and curves are less than 30, and there is some subluxation, 2 millimeters or more of the vertebral segments, but there are no anterior osteophytes that would stabilize this area. So again, also you need for this second method of treatment, which is going to be decompression, correction, and stabilization only of the area of decompression, you should have no thoracic hyperkyphosis and well-balanced spine. Then, like this case, you can cause this decompression of the affected segments and do decompression well and fixation only of the area that you are going to destabilize with your decompression and cause fusion around this area. Usually you need these two maneuvers. On the concavity, you need to put a distractor on your fixation to cause distraction on the concavity. So this is a very important step. And on the other side, on the convexity, you need to cause compression on the convexity. So these are very important, especially for limited fusions. The third scenario, the entire lumbar curve, in addition to the necessary decompression, is included in the instrumented fusion. So all the lumbar curve, or all the curve, is going to be not only the area you are going to decompress, but all the curve is going to be decompressed at the necessary levels and fixed and tried for correction and fixation and fusion. When you are going to use this scenario, when the symptoms of primary back pain here, back pain is a major issue here, and these curves are more than are usually more than 45, more than 2 millimeters of subluxation, no anterior osteophytes, so there's no enough stabilization of those segments, and still reasonable coronal and sagittal balance, so you don't need to go to the pelvis. Level 4 of treatment, because I'm going to show, this is level 3, the whole curve. Level 4 is going to be adding something anterior to the fixation, not doing all the job from the posterior aspect. You need something interbody, and usually I use TLEF. The conditions here are if you need to correct flat back and increase lordosis, and in those patients that are hazardous for pseudoarthrosis, like smokers, patients with diabetes, osteoporotic patients, there should be no anterior osteophytes again and no thoracic hyperkyphosis. But if there is thoracic hyperkyphosis as well, you will need here to correct the whole spectrum, taking in consideration also fixing and correcting the thoracic spine. I will move now to the clinical implementation or practical implementation of the last 3 scenarios. I'll show you some demonstration that I prepared for that on how to correct this scoliosis. You put your implants, like I've done here to this demo with scoliosis, and we bend the rod into the correct position. So this rod is in a perfect position, having lumbar lordosis and thoracic kyphosis. I will apply it then to the deformed spine. It's going to be a correctly bent rod applied to deformed spine. So this is the rod. I'm going to apply it now in the position the spine in. So it's going to be, as I just said, a correctly bent rod applied to the deformed, now flexible spine after doing your decompressions, so that the correction is not going to be dangerous and tether anything of the neural elements. So I will put this rod to the deformed spine, and then it's going to look like that. I'm sorry. So it's going to look like that. What I'm going to do now is that I will use, first of all, you have two problems. First problem is that some of the screws that are applied to the deformed vertebrae are going to be far away from the rod. So we have one of two methods of bringing them to the rod first. The first one is using of persuaders that I'm going to apply now on this demo, like this device that gets attached to the head of the screw. And by using this device, it is going to pull up the head of the screw with the vertebral body towards the rod. And this causes reduction of those vertebrae to the correct position, or almost the correct position, on one plane, and causes some derotation as well. You're going to see now how I'm doing that. The problem with those patients are these are osteoporotic patients. So sometimes the use of these persuaders are causing some pull out of this screw. It's going to pull on the vertebra to reduce it. And this causes some pull out of these screws. So the other solution is to use what we call reduction screw that I'm going to show you now, that solves the problem if the persuader is going to cause pull out of these screws. So you can see now that when I remove these persuaders, I've already reduced those vertebral bodies to the rod using these persuaders. And I'll show you now the alternative of doing that in severely osteoporotic patients when you're afraid of pulling out the screw out of the vertebral body by using those persuaders. So you can see now how much reduction we got primarily before then derotating the vertebrae into place. In a second, I'm going to show you this reduction screw, and I'll tell you what's the idea of using it. This is the reduction screw. The idea is that we have now the whole length of this head, all are serrated. So even if the rod is here, we are going to apply the cap from here, and all this distance, the cap is tightening the rod in place and getting the whole vertebra reduced without causing too much of pull out of these screws. Then the derotation, which is very important as well. We put those catchers to the rod, and then we are going to rotate the rod to face its normal position. So we will rotate the rod so that the lumbar lordosis face the correct position and the thoracic kyphosis faces the correct position, and this is going to derotate the whole vertebrae to place. We're going to see this now. Then we tighten the caps after doing this. This is what happens in real life in open surgery. And you are going to see how much derotation we got just by making the contoured rod, which we know is contoured to the correct position, look towards the place it should look to, and that derotates these vertebrae beautifully, as you can see here. See how much derotation we got. And by doing the same with another rod on the other side, putting it also putting it also to the deformed spine, and then rotating it into place, will get you some more derotation of these segments. As you can see by this derotation maneuver. I told you also that we can use TLEF in order to put something in the interbody space as anterior as we can. And this demo is showing you, this is the area we're going to play with. Around these facets, we are going to osteotomize these facets. That takes you laterally into the disc space. You evacuate the disc space here and get your implant as anterior as possible. This restores lordosis and helps you in reduction so much. The last thing we are going to talk about, where to stop distally in long constructs of degenerative scoliosis, L5 sacrum or ilium. This is actually a talk that I give in 30 minutes in Cleveland Clinic Spine Review, but I can summarize that significant pelvic tilt forming part of the deformity means that you go to the iliac fixation directly. Stopping at L5, even if the L5-S1 disc looks nice and good, high chance of redo surgery for L5-S1 degeneration later on. And if you stop at S1, also the rate of pseudoarthrosis at L5-S1 for long constructs is a true threat. So it's better if you can to go to the pelvis for fixation. Then the last thing is using level 6 of treatment when there is a need for significant osteotomy of the spine. Patients whose deformity demonstrate more than 30% correction on bending radiographs do not require osteotomy, but curves that are corrected less than 30% considered stiff deformities and need deformity correction by osteotomy. Mainly it's PSO and VCR. There's not enough time to describe all this, but this is what a segment with osteotomy will look like. This needs another talk and another day. So thank you for listening, and I hope that clarified some pearls from the OR for deformity surgeons trying to correct degenerative scoliosis. Thank you.
Thank you so much, Professor Al-Fatah Saud, for this very interesting talk. Thank you so much, sir.
You're welcome, sir.
If we have any questions to Professor Al-Fatah, because we are in a short of time for the live surgery.
It says, thank you, Dr. Professor Al-Fatah. بهاء قرنة.
أهلا وسهلا بحضرتك يا فندم.
الله يخليك. Just you mentioned a bit about what we call the focal surgery for symptomatic part.
Yes, sir.
Yes. Sometimes it's very, very difficult because a lot of ladies, especially in Egypt, they complain for a lot of complaint, not single complaint, like radiculopathies, low back pain, whatever. And sometimes it's very difficult to persuading this patient to do single operations for this symptomatic part.
Yeah, I agree. The problem here, if you allow me, is that I said that we don't receive enough patients early on for this kind of surgery in Egypt. All of them come very late. Number two, that with some cultural deficiency, there is a problem of specifying really that this radiculopathy is the cause of her problems. That's why I said we have to confirm that by dynamic MRI, by CT, to see where the osteophytes are, relate this to symptoms, do EMG, do selective injections if they cause real change of symptoms. And the other very important thing is that the rest of the conditions should be there. There should be no instability in this area. There should be anterior osteophytes that stabilize this area. If you are going in your CT to plan for surgery and you see that you need to remove most of the facets and you need to do this for decompression, you cannot do limited decompression because you need fixation. So there are a lot of conditions before knowing that this selective decompression is going to work.
Thank you very much.
Very interesting question. Thank you, sir.
We are now ready for the live surgery transmitted from India, endoscopic spinal fusion. I'm trying to make a connection with Professor Malcolm. Yes, we are in.
And can somebody please focus? Where is that Vikram? Handicap maker focus when I'm talking.
Professor Malcolm, we are ready, sir.
Can you see me? And come on, focus on me. Like select my button actually.
Yes, sir.
Surely zoom and make it one. Hello, good evening.
Good evening, sir.
Can you
Thank
see
you
me?
so much, sir.
Loud and clear. Mama light. Hello. Lights are here. Hello. Hello.
We can see you, sir. We can see you, sir.
Can you hear me? We are going to remove this disc. It's a left paracentral herniation at L5S1. Can you focus here? Okay.
Yes, sir.
What we have done is can this be focused upon? Take it up and focus. What I've done is I have marked the midline and I have marked my entry into the spine. I am ready now. Can you please show the camera view, please? Now, what I've done is I've just dissected a bit of the paraspinal muscle so that it becomes easy for me to start the surgery and not waste your time. This is the inverted view. This is the inverted view. This is the spinal lamina junction. Can you please show that previous CT scan? See how images become here. Yeah. Focus on that. Now put the camera on only one thing more. Can you show that please, Shirley?
Yes, sir.
Yeah. As you can see, my two instruments are meeting exactly at the spinal lamina junction here. From here, I've stripped the muscle in parallel. I'm using a plasma which generates only 40 degrees temperature, but it helps me to cut away the muscle, or strip the muscles rather than cut it, I'll say, and push it away from my surgical. Stop firing, please. And here is the spinal lamina U. This is the U. This is where the deeper layer of plenum is attaching itself. As we come a little laterally, you will see that they are coming towards the facet. And here a little. The physical edge that's coming down on it. Okay. And this is from where we go in laterally, and then we will go for our twist. So now I will start with the burr. I will be using the UV burr. Small cutting burr. And you can see how we connect the burr here. It is a guarded burr. Can somebody please start? And as you can see, I'm now cutting away the lamina, superior lamina, inferior edge, and the U. I'll be going up on the spinous process. If I wish to go on the contralateral side, then I have to cut the spinous process also, the base of the spinous process also. For the sake of demonstration, I'm showing it to you, so it's not really needed today. So we have a paracentral disc, and which ideally be only on our side, but if you're going to watch it, you might as well watch it full. And as you see, I'm pushing away, I'm working away over here at the edge. You're coming out on the outer plate now. We are expanding the outer plate a bit. Am I audible to you guys? Can you all hear me?
Yes, sir. Oh.
I'm coming a little laterally. I'm turning my scope a bit so that I can see the lateral vessel which I'm cutting. I'm cutting away the IFP right now. I'm cutting away the IFP. Stop, sir. I'm cutting away the IFP. I'm cutting away the lamina edge, and I'm exposing the A1 and the undersurface. This is the spinous process here. One, please. When you are extra flavor, I don't mind using a sharp cutting work.
Mama.
I'm going a bit towards the midline. Use pressure against the bone only when you feel the bone. Otherwise, please use no pressure. You can see that gradually moving up on the lamina. Until we will come to this separation zone of the flavor. After separation of the flavor should occur. here you see the separation and the midline left. Slowly we are coming to the midline and going more into the phone. Stairs rather than down, because you can see the midline here, you can see that the airway will open up here. Now we are again going to work out our aim, visiting the lamina. Direct knee over here, a few of my doctor friends. Especially these residing presence. They still and you can see that the level is now beginning to separate itself from the undersurface to the lamina. And you will soon be able to try to cover the laterally. There is some soft tissue airway coming here to the front pad piece. And the bone piece. Thank you. And I think you can see much more clearly now. Okay. And I have a small bit down to hook up with the touch. Now, here, please. Yes. Taking a small tulip. Please focus on your hands, please. Clean the water. As you can see, I'm separating out the tulip. Very short tulips. Camera. And here you can see that I'm stripping away the paper.
تمام.
This is a midline clear. Okay, now we're going to do this flavor and we're going to expose the surface and then go for this. तुम्हाला पंच दिलेला ना आक्रोस्कोपीचा तो वापर केला घेतली काय नाही तुला आता Use an laparoscopic punch also. Using an angled laparoscopic punch. medicine there. Now first writing away the outer layer of the phlegm, the harder layer. Put in the softer layer now. After the medicine. And releasing of the exit part, are you showing this? Yes. Then, see that part. First piece of paper. I must pause and appreciate the instrument that you like now. It's a very punch. Manufactured by Korea. Seems like now. Right. See, the spinal part of the tube. Part of the SCP complex. Appreciating right now. Sure, that it will really do this kind of voice on ICM this form. Zero system about the starting pattern. Some pattern by checking the fluid. So as you see here, you can see the vascular lines on the surface of the vascular and the surface of the phlegm. What I can do is use the plasma. Don't contribute that. Yes, now 5 please. Blue. This is unknown vascular surface of the phlegm, which are forming. Stop, please. Fire. vascularities, so I can now packet nicely. This is a contralateral flavor. Flavor on the opposite side. Another distance please. To try and increase your field at the same time your property compression. I know it's not needed in this case, but for the sake of demonstration, I'm going to demonstrate to you the capability of the how easy it is to hold the top compression. There's some more vascular. I'll please. Thank you. Please. Please. See how thick the flavor is on the contralateral side. Now same thickness on our side. The actually shape is more on the other side. See how they're compressing across the intestinal part. One not being given presentation script is continuing for that today. Showcasing the improved lab, showcases capabilities. All backward time across the world. Actually, master unit I time song and the runtime efforts. It's a positive impact on all of these people have so massively contributed. There are no words to express their gratefulness now. Now what you see across, what you see across is the lateral recess of the opposite side. This is the bone here, side. And in the bone here. This is the bone and strip. The bone, lateral recess. This is the flavor below the lateral recess. So the moment I remove that, I've opened up the lateral recess on the opposite side. I can even osteotomize this SAP. Take and remove some of my videos to show that not indicated here, so I intend not to do it, but just being a bit correctly before I can see for this. Hope you're finding this entertaining. So the opposite exiting foramen, and you are opening it up. Nice. Okay. Nice. Hello. Are you in love? Removed the opposite receptor. The other vesicle cyst, you have removed it by now. Okay, so it's so easy to do all this work. Okay, the level of the pillar there, you go for it. You open up this cloud. One piece number 2 are individual design once the design units. Okay, I use the example of stop, please. You can see the opposite side. The one fire, please. You can see the opposite side exiting. Can you see this? Done. Okay. Vasculature, touch. Yeah. Touch. Touch. Thank you. Now. So can you find the yellow one, please? Here? Very low temperature probe. Not like a traditional probe. Please. See? Now, you will come on our side. Work on our side. This. You have a yes. You have a discount. See the maxilla. Okay. See here. Maxilla. Okay. How it is Thank you. I'll leave this young now. Stop. Stop. Fire. Stop. No, small punch, one more punch. No. Okay. Now we will be taking my lateral CM shoot, please. Sorry, please show that screen and show that screen.
Yeah.
And I'm holding my scope here. You can see the axillary root, you can see the S1 root, it's very horizontal. It's not the typical root. Okay, and we have to come in the axilla of the root, and now we go to the twist. Now I'm just confirming my position. So you can see the Siam. Then come here. Table up, please, sir. You can see my instrument nicely inside. Okay, there's no traction, no pressure on the roof. You can make more space laterally to achieve more fusion. You just need to undercut the more set, which I'm avoided. Proper. Aliyan, please. Rotate, please rotate. Rotate it, yeah. Now, come on, now take a shoot again. Maybe better one. Thank you. Can you see that I'm in the L5S1 in this space? With the horizontal please, guys. Come on, natural level spinal thing here. Come on, rotate it. You have to do the other one. Yes, rotate this one. And John, give me a better shoot. Come on, you can give me a better shoot for my friend. What we get after finding the proper shoot of the CR. Thank you. Can you see there in the alpha S like this? I'm comfortably inside. Now I'll be using this punch. And we will start with the decompression surgery. I request you to do this for a couple of minutes more, then you can cut off, and I can do my little work and you can go into your confidence. So that you make the space over there. Okay. Now can I have a dispense, please? Okay, see, I'm done here. Come on, my hands up in here. Everybody watching the TV, you know, all of the see. This hello, everybody. Thank you for being with us today. And it's time to say goodbye. Sorry, the fragment is broken. Can you see this, guys? Hello? Can someone put some light on me here? Can you zoom on it?
Yes, yes.
Thank you. There's a fragment, there is stone, more to come out. Thank you from India. So may I have your permission? I'll continue with my work for some more time and sign off here. I thank everyone for the invitation that was given to me. God bless you all. I hope one more of you learn to love beauty. Pick up to it, adapt to it. Fantastic beauty certainly trying to come. Say thank you for the most. You can see.
joint is even better to
Stop, no?
on sharing your stop video. Hello. The window close करून टाका नाही आपलं. त्याचं दिसेल त्यांचे stop video. एक स्क्रीन मध्ये दाखवतो
काय सांगतो?
हा फक्त एक स्क्रीन दाखवतो एक
Thank you so much. By the end of the live surgery, we come to the best end of these 2 days in the Spine Specialty Day. At the end, I would like to thank Endovision Company for sponsoring this meeting, with special thanks to Dr. Vlad Teplatinesky from South Korea, for the chief consultant of Endovision, for organization, helping in the organization of these 2 days. I would like to thank all the national and international eminent guest speakers. Inshallah, we will see you in the next specialty days, which will be after 3 weeks from now, the shoulder specialty days, with eminent speakers from Brazil, from Switzerland, from UK, from Canada, from Poland, and of course from Egypt. Thank you so much. ومتشكرين جدا اساتذتنا الافاضل. شكرا دكتور بهاء بيه، وشكرا اللي شرفتونا. استمتعنا بوجود حضراتكم معانا يا فندم، وان شاء الله نراكم على خير في السبيشاليتي دايز القادمه ان شاء الله يا فندم. شكرا.
شكرا، ربنا يكرمك ان شاء الله. السلام عليكم.
وعليكم السلام ورحمه الله وبركاته.